Now in this class we'll be starting with the vascular pathology, right? So we are going to discuss about the problems which are going to occur for the vessels, the vascular pathology, sir. So first we will do the vascular pathology. What are the problems that can occur with the vessels? Okay, the main important topics, that's the vasculitis. After that we are also going to discuss about atherosclerosis. Okay, sclerosis, the hardening of the blood vessels. And also we'll be saying some important tumors that are going to arise for the blood vessels, the tumors of the blood vessels. Okay. Now in this class, let's begin with the vascular pathology. Okay, vascular pathology. Now here you can very clearly see this is a normal, sir. Okay, the normal histology. On the left side I am showing you, say this is how an artery is going to look like. So this is the lumen of the artery. The arteries are going to have a thick wall. The wall of the arteries are going to be thick. Okay, and here see in the veins are having thin walls. Veins are thin walled, arteries are thick walled. But the point which I want you to know is, see, so your blood vessels are having how many layers? Your blood vessels are made up of 3 layers. 3 layers are there. What are they? The innermost layer, this layer is called as the tunica intima. Okay, this is the tunica intima, sir, intimal layer. Okay, so the tunica intima, which is lined by the endothelial cells, the endothelial layer, tunica intima. Now after that, so this muscle layer which I am highlighting here, the muscle layer is called as the tunica media. Tunica media is made up of the smooth muscles. And the last layer is this layer, this is the tunica adventitia. Okay, that is the adventitial layer. So now tell me, how many layers are there in the blood vessel? In the blood vessel there are 3 layers, tunica intima, tunica media and tunica adventitia. Same with the veins also. Now apart from that, what else you should know? Look here, this is a tunica intima, tunica media, and here is tunica adventitia. Okay, 3 layers are there. But guys, have you appreciated that, so there is this blue color wavy lining is there here. Okay, so this blue color wavy lining which is present between the tunica intima and tunica media. So what is this? So this is called as internal elastic lamina. Okay, elastic fibers. So this is called as the internal elastic lamina. Even here you can see very clearly, I hope you can see here. So this is the internal elastic lamina. Dekho, internal elastic lamina. And between tunica media and tunica adventitia, there is one more layer present, this blue color layer. Okay, so this wavy layer which I am highlighting right here, this is called as the elastic lamina only, but that is external elastic lamina. Internal elastic lamina, see, this is the internal elastic lamina, this one, and here this is the external elastic lamina. Okay, now in your exam they can ask you, so these elastic fibers are stained with the staining. So what is the stain that is used to look at these elastic fibers? MCQ. Here you can very clearly see, so the histology which I am showing you, this is actually a vascular pathology. Later we will discuss. It's a type of vasculitis. But here, are you able to appreciate this wavy fibers, the internal elastic lamina, sir? So remember, Verhoef Van Giesen stain. Okay, MCQ. The Verhoef Van Giesen stain. Okay, it is commonly used. Say it is commonly used to visualize the elastic tissues. Okay. So the elastic tissues are stained by, the elastin fibers are stained by Verhoef Van Giesen stain. Okay, that's the MCQ. Now after this, let's begin with the vascular pathology. Say something normal I have explained you. Blood vessels, normal histology I have explained you. So the first vascular pathology that I am going to discuss is vasculitis. What exactly is vasculitis? Vessel, right? Vasculitis. In the vasculitis, what is that vas? Vas means vessels. Itis means inflammation of the blood vessels. Okay, so vasculitis, it is an inflammation of blood vessel. Okay, it's the inflammation of the blood vessels. Why inflammation of the blood vessels, sir? See, the pathogenesis, the pathophysiology is very poorly understood. There are different types of vasculitis, there are different reasons, but in general, the pathophysiology of the vasculitis is poorly understood. Idiopathic, sir. We don't know why exactly the vessels are getting inflamed. In different conditions, there might be different reasons, but in general, I am telling you, the pathophysiology is idiopathic, sir. Okay. Now, how many types of vasculitis are there? So wherever you go worldwide, the same 3 things. Vasculitis is divided into, okay, 3 major types. 3 types of vasculitis. So one is large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. For example, if you are having vasculitis to larger blood vessels, okay, big sized blood vessels, then it is called as a large vessel vasculitis. Okay, large vessel vasculitis means the blood vessels which are involved in the process of inflammation are larger in nature. So large blood vessel getting vasculitis is a large vessel vasculitis. Simple, right? So medium vessels, if they get vasculitis, that's called as a medium vessel vasculitis, and small blood vessels, if they get vasculitis, that's called as a small vessel vasculitis. Now examples are very important, sir. What are the examples of large vessel vasculitis? Large vessel vasculitis includes temporal arteritis. Okay, not arthritis, arteritis. Arteritis means inflammation of the arteries. So temporal arteritis, also called as a giant cell arteritis. Okay, temporal arteritis, the temporal artery getting inflamed. Temporal arteritis or giant cell arteritis. And Takayasu. So temporal arteritis and Takayasu, T for T. See, TT, both are TTs. Okay, temporal and Takayasu. Both these are large vessel granulomatous vasculitis. I will discuss. Now, medium vessel vasculitis. Medium vessel vasculitis includes polyarteritis nodosa, PAN. Okay, we have discussed about the polyarteritis nodosa in the topic of in the topic of necrosis also. Polyarteritis nodosa. Okay, PAN. What type of necrosis will occur? Fibrinoid necrosis. We have discussed in the cell injury. Okay, necrosis topic. Now, Kawasaki disease. Okay, Kawasaki disease, which is going to occur for the children, especially before the 4 years of age. Okay, which is usually seen in small children. So, we'll discuss polyarteritis nodosa, Takayasu arteritis or Takayasu disease, and thromboangiitis obliterans. Okay, thromboangiitis obliterans, also called as the Burgess disease. This is the exact question asked in 2019 June FMG exam. Okay, so thromboangiitis obliterans is also called as, is the other name for Burgess disease. Simple MCQ, Burgess disease. Okay, see, thromboangiitis, in the name itself is there. Angiitis, inflammation of the blood vessel. Thrombo means occlusion. The blood vessels are getting occluded and even thrombus is going to form. Okay, because of the thrombus, the blood vessels are getting occluded. Okay, thromboangiitis obliterans, obliterated. Okay, now small vessel vasculitis. What are the examples of the small vessel vasculitis? The small vessel vasculitis includes Wegener's granulomatosis, microscopic polyangiitis, and Church-Strass disease. Okay, Church-Strass disease. What are three small vessel vasculitis? Wegener's granulomatosis, Wegener's. But remember it like Wegener's. Why? Later you will understand Wegener's. Okay, but generally Wegener's granulomatosis, microscopic polyangiitis, and Church-Strass disease, as well as one more thing, Henoch-Schönlein purpura. Okay, Henoch-Schönlein purpura. It is also coming under small vessel vasculitis. Sir. So now just tell me, how many types of vasculitis are there? So vasculitis, first of all, it is inflammation of the blood vessels. There are three types of vasculitis: large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Large vessel vasculitis examples: temporal arteritis and Takayasu arteritis. Medium vessel vasculitis includes polyarteritis nodosa, Kawasaki disease, and thromboangiitis obliterans, which is also called as the Burgess disease. And small vessel vasculitis includes Wegener's granulomatosis, Church-Strass disease, microscopic polyangiitis, and Henoch-Schönlein purpura. Done. Enough. So you know the classification also. Now after this classification, now you need to understand, so this vasculitis, in this condition, it is associated, usually this vasculitis is a condition associated with ANCA. Okay, in vasculitis, you are going to have this ANCA, sir. In which vasculitis I will tell you. First of all, what is this ANCA? ANCA means anti-neutrophilic cytoplasmic antibodies. Now whoever have this vasculitis in their blood, you will find this antibody called as ANCA, anti-neutrophilic cytoplasmic antibody. How many types of ANCA are there? There are actually three types of ANCA, but for your exam purpose, mainly two types of ANCA. What are they? P ANCA, C ANCA. There are two types of ANCA, P ANCA, C ANCA, sir. Now what exactly is this P ANCA stands for? P for perinuclear ANCA. Means antibodies are produced. Okay, antibodies are produced against what? Against the neutrophil. See, name. Anti-neutrophilic. Where the antibodies are going? Antibodies are going and attacking the cytoplasm. Anti-neutrophilic cytoplasmic antibody, but okay. But then what is this P ANCA, sir? What is P ANCA? See, now look, around the nucleus. What you are seeing here is around the nucleus. You are having this fluorescence. Means antibodies are going and getting deposited around the nucleus, sir. So perinuclear, P stands for perinuclear ANCA. Okay, and what is C ANCA? Okay, what is C ANCA? Before telling you C ANCA, see, In Priyanka, dekho, Priyanka, sir, antibodies are getting produced, okay? Antibodies are getting produced, but against what? Why antibodies are getting produced? We don't have a proper reason. But antibodies are produced against a component called as myeloperoxidase. Against this myeloperoxidase, the P-ANCA antibodies are produced. So P-ANCA is produced against myeloperoxidase. The antibodies are going and getting deposited around the nucleus. Done. Next, C-ANCA. What the hell is this C stands for? C stands for, it's a cytoplasmic. Okay, so it's a cytoplasmic ANCA. See, entire cytoplasm. Okay, not just the perinuclear region, not just the perinuclear region. The entire cytoplasm is giving fluorescence because the entire antibodies are deposited in the entire cytoplasm. All the antibodies are deposited in the entire cytoplasm. So it is cytoplasmic ANCA. The other is perinuclear ANCA. There are two types: perinuclear ANCA and cytoplasmic ANCA. P ANCA is produced against the myeloperoxidase. Okay. Then C ANCA is produced against. It is produced against proteinase 3, an enzyme called as proteinase 3. It's produced against an enzyme called as proteinase 3, sir. Done. Now, the questions which will come in your exam. From here, these are the exam questions, sir. The exam questions, sir. So, okay, P ANCA, C ANCA, two types of ANCA are there. Okay, understood. Where these are seen? Where these are seen? See, this P ANCA is seen in many conditions, sir. It's seen in many conditions, like especially in the small vessel vasculitis. Small vessel vasculitis, microscopic polyangiitis, Churg-Strauss syndrome. Okay, we have discussed the microscopic polyangiitis, Churg-Strauss syndrome. In the small vessel vasculitis, there is presence of P ANCA. And where you will see C ANCA. Okay, the C ANCA, it is seen in Wegener's. That's why I said you. Wegener's, W-E-C, C, not Wegener's. Why I ask you to remember? As Wegener's, because of presence of C ANCA. In Wegener's granulomatosis, now you will get it out. Sir, what exactly is this Wegener's granulomatosis? Where we have studied about this? Wegener's granulomatosis. Look here guys, Wegener's granulomatosis is also a type of small vessel vasculitis, right? So in Wegener's granulomatosis, 75% of the cases, in 75% of the cases, there is presence of C ANCA, and in 25% of the cases, still P ANCA is positive. So P ANCA is present in Wegener's granulomatosis, true. It is present in microscopic polyangiitis, Churg-Strauss syndrome, true sir. But in 75% cases of the Wegener's granulomatosis, there is present of C ANCA. Okay, P ANCA is present in many other conditions, even in inflammatory bowel diseases. Okay, inflammatory bowel diseases, ulcerative colitis also, there is presence of this P ANCA. Okay, now done. So what we have seen so far, we have seen normal histology completed. One important stain. What is the important stain? Verhoeff Van Janssen stain. Okay, Verhoeff Van Janssen stain is used to stain the elastic tissues, and the classification of the vasculitis, small vessel vasculitis, medium vessel vasculitis and large vessel vasculitis classification is completed. After that, I have explained you about the ANCA. ANCA are nothing but the antibodies. There are two types of ANCA, P ANCA and C ANCA. P ANCA is seen in Churg-Strauss disease as well as microscopic polyangiitis. Wegener's granulomatosis, it shows both P ANCA as well as C ANCA. Mainly C ANCA, 75% of the cases. Now after this, now look here and tell me. Sir, just simply I am giving an image based question. Now, there is this old woman, okay, 60 years old woman. Now, she is having severe headache. Now, if you look at her temple region, then this temple region, are you able to appreciate this inflamed arteries, this inflamed blood vessels, sir? Okay, I hope you can appreciate that. So, what exactly is this type of vasculitis? So, now this is a giant cell arteritis, sir. So, now this image itself is telling you. So, giant cell arteritis, just tell me, sir, giant cell arteritis is going to be seen in females or males? It's going to be seen in females or males? Mainly females. Older females or younger females? Older females. Okay, so let's write the important points one by one, sir. One by one, let's write the important points. Okay, so this giant cell arteritis, right? AKA, also known as temporal arteritis. Okay, it's also called as temporal arteritis. Seen in which sex? Mainly seen in females. In your question also, the question will come, the female of age how much? More than 50 years, sir. Not an younger female, but an elder female. So what is the most common complaint? What is the most common clinical feature? So the most common complaint, okay, the most common complaint and the most common presentation is unilateral headache. Okay, she's going to have severe unilateral headache, temporal pain. She's going to have a headache, sir. Why? Why she is having headache? Because the most common blood vessel, okay, the most common vessel involved. You know what is the most common blood vessel that is involved in this type of vasculitis? This is in the name itself. It is a temporal arteritis. So it's a superficial temporal artery. Okay, superficial temporal artery. Okay, the superficial temporal artery that is getting inflamed, sir. That is a temporal arteritis. Okay, temporal arteritis. See, most commonly it is seen in females. It doesn't mean it's going to occur only in females. So most commonly it is going to occur in females, but yeah, males also will get this. Okay, males also will get this. Okay. Next, so the most common blood vessel that is involved is the superficial temporal artery. Then apart from superficial temporal artery, even facial artery. Facial artery can be involved, sir. Facial artery. Now, what is the most specific presentation? Most common presentation is unilateral headache. Then what is the most specific presentation? Any idea? Most specific, you know, the facial artery is going to take a turn like this. At the angle of the mandible, the facial artery is going to take a turn like this. Okay, it's a tortuous blood vessel, the facial artery. If the facial artery is involved, if the facial artery is inflamed, whenever you open your jaw, that's going to cause pain. So that's going to cause a pain. So that's called as a jaw claudication. Okay, these are all MCQs. So jaw claudication is the most specific presentation, guys. Most specific presentation which you should never ever forget about it. Okay. So any other things, any other problems that are seen in this temporal arteritis? See, usually these patients will also have the problem with the joints. Okay. So joint pains. The joints are going to be painful. Multiple joints are going to be involved. So this condition is called as polymyalgia. Okay, joints and even the muscle pains will be there. Okay, polymyalgia rheumatica. Okay, so polymyalgia rheumatica, joint pain will be there, arthritis will be there, muscle cramps is going to be there. So this polymyalgia rheumatica is associated with which type of arthritis? It is associated with giant cell arthritis or temporal arthritis. Okay. Next, the main problem with this patients is, so this inflammation might involve, okay, this inflammation can even spread to the optic nerve. Okay, so that can lead to visual loss. So that's the most the problematic thing. Let me write here. Severe complication. Severe complication. The complication is going to be vision loss. Okay, so vision loss, the inflammation can spread to the optic nerve, ophthalmic artery, so that can lead to vision loss. Okay, sudden vision loss can occur. So that's why it's the most severe complication. So whenever a patient comes to you, and you diagnose that this patient is having temporal arteritis, and if she is having blurring of the vision, okay, if she is having any visual abnormalities, then immediately start steroids. Okay, so immediately start the steroids. Why steroids? Okay, why we have to give the steroids? Because steroids are the they are going to be anti-inflammatory. They are going to stop the inflammation. Okay, they are going to stop the inflammation. Also start aspirin. Okay, so the blood vessels are not going to in the blood vessels, clot is not going to occur because of the inflammation. The clot formation will not occur, sir. It's an antiplatelet aggregate, right? Aspirin is an antiplatelet aggregate. So thrombus formation will be stopped. So these are the severe complication, that's the vision loss. So whenever a patient comes to you with a visual abnormality, immediately start with the steroids and aspirin. Okay. So now tell me important points about the giant cell arteritis. The giant cell arteritis first. Is it small vessel vasculitis or large vessel vasculitis? It's a large vessel vasculitis, sir. So it's seen in males or females? Mainly seen in females of elderly age group, more than 50 years. Okay, what is the most common blood vessel involved? The most common blood vessel that is involved is superficial temporal artery. Okay, apart from superficial temporal artery, multiple arteries can be involved. Even facial artery can be involved. So this involvement of the facial artery can lead to jaw claudication. Whenever the person will try to open the mouth or do any movement, that will cause the pain, jaw claudication is going to be seen. Okay, what is the most severe complication? Vision loss. Okay, blindness is the most severe complication, and joint pains will be seen, joint pain, arthritis will be seen, that is called as a polymyalgia rheumatica. Okay, so now what I'm trying to put into your mind, your mind here. See, this is the blood vessel. Okay, this is the blood vessel which is involved in the vasculitis. Okay, this is the blood vessel which is involved in the vasculitis. So because of the inflammation, the lumen of the blood vessel is getting narrowed. The lumen of the blood vessel is getting narrowed. So the perfusion to the tissues will be greatly compromised. And not only that, here giant cells are seen. Giant cells. Where do you see usually giant cells? Giant cells, epithelioid cells, macrophages. What they will form? Granulomas. Sir, here there is inflammation. But is which type of inflammation? It's a granulomatous inflammation. Remember, sir, G for G, giant cell arthritis. It's an example, right? The giant cell arthritis on histology. It's an example of granulomatous inflammation or granulomatous arthritis. So granulomatous inflammation is going to be seen. Okay, now how to put the diagnosis? See, this is the temporal artery, sir. This is the temporal artery. Now what you need to do is, so you need to do microscopic examination first. The histology is microscopic only, no? So to take this blood vessel, first what you need to do? First you need to do the biopsy. You need to take this blood vessel, sir. Okay, so you need to do the biopsy of superficial temporal artery. So biopsy of the superficial temporal artery. Now important point is, sir, how much artery you need to take? What should be the length of this biopsy piece? How much length you need to take the biopsy? So the optimal length is going to be somewhere between 3 to 5 centimeters. 3 to 5 centimeters. Why you need to take 3 to 5 centimeters? Or why 1 centimeter biopsy is not enough? Why it is not enough? Why you need to take 3 to 5 centimeters, such a large piece? 5 centimeters is this much, right? Why you need to take such a large piece of this temporal artery? It's because, see, there is inflammation, okay, the temporal arteries are involved, the superficial temporal artery is involved, okay. But do you think there is a continuous inflammation? There is not continuous inflammation. There is segmental inflammation, MCQ. So, right here, the giant cell arthritis, it's a segmental inflammation. Okay, there is a segmental inflammation of the temporal arteries. So, for example, if you take a small piece, okay, for example, if you take a small piece of artery, only 1 centimeter, maybe in that particular area, there is a chance that there is no inflammation. So, you will miss out the diagnosis. So, for that purpose, you need to take a large piece of temporal artery biopsy. Then what you will see? You will see the segmental inflammation, segmental granulomatous inflammation is going to be seen with the giant cells, epithelioid cells, okay, are present, sir. So granulomas are positive. Remember, granulomas are present, sir. Okay, so these are the important points which I want you to know. Even in this image, you can very clearly see the temporal artery biopsy, TAB. TAB means temporal artery biopsy. Temporal artery biopsy is performed in a patient in a case study. Okay, so that's a temporal artery biopsy. Now, we are done with the first step of vasculitis. The giant cell vasculitis or the temporal vasculitis is completed. Now, look here and just tell me, sir, can you tell me what is this vasculitis which I am showing you here? What is this? Can you tell me, sir? Here, see, this is the arch of aorta. Okay, the bigger blood vessels, large blood vessels, the arch of aorta is getting involved. Okay, do you know what is this disease called as? So, this disease is Takayasu. Okay, Takayasu arthritis. Now, other important points, aka Takayasu arthritis, it is also called as, I have shown you which part is going to be affected, aortic arch. So, also called as aortic arch syndrome. Okay, this is also called as aortic arch syndrome. So, the aortic arch is going to be affected. Not only that aortic arch, see from this aortic arch, the inflammation is going to spread to the blood vessels which are coming from the aortic arch. For example, look here, from this aortic arch, these blood vessels are coming out. Now this inflammation will also spread into these blood vessels. Now from this aortic arch, the inflammation may spread into the subclavian artery. Subclavian artery, we know the subclavian artery is going to continue as axillary artery. Axillary artery is going to continue as a brachial artery. Brachial artery is going to continue as the radial and ulnar arteries. So inflammation is going to spread through these bigger arteries, larger arteries. So when these blood vessels are now inflamed, the blood flow through this blood vessels is going to be greatly compromised. Less blood flow, inflamed blood vessels. So when you try to measure the pulse, are you able to appreciate the pulse in the upper extremities? No. No, sir. Because the blood vessels are involved, the aortic arch is involved, the subclavian arteries are involved. Okay. So now this disease is also called as aortic arch syndrome. One more name, that is pulseless disease. Okay, it's also called as a pulseless disease. Now my question to you, sir, this aortic arch syndrome, is it going to be seen in males or females? Males or females, sir? Again females. Lucky males. Okay, we are all lucky, we are not getting these diseases. Okay, so they are going to be not getting in the sense, mainly it's going to occur in the females. So females, but which age group? Important. Less than 40 years. Okay, means younger females, 30 years, 35 years, 25 years. So a younger female who is presented to your clinic, when you try to measure her pulse, the pulse is not there. There is very weak pulse, feeble pulse, pulseless patient. What do you think? What do you suspect? Young female, Takayasu arthritis, aortic arch syndrome. Okay, so now in one of the exams, this question was asked: most common blood vessel involved. The most common blood vessel involved. Say blood vessel. They are asking the blood vessel. It is subclavian artery. Okay, subclavian artery. If you have to pick one single best answer, it's the subclavian artery. Because of the involvement of the subclavian artery only, the pulse is not going to be properly felt. Okay, so what is the most common presentation? The most common presentation is going to be weaker pulse in upper extremities. Okay, weaker pulse in the upper extremities. Now, on microscopy, whenever you do microscopic examination, what you will see? Sir, is it a granulomatous vasculitis or is it a non-granulomatous vasculitis? You know, in the inflammation topic, we have discussed there are two types of inflammation: granulomatous inflammation, non-granulomatous inflammation. If there is presence of granulomas, then it is called as a granulomatous inflammation. Okay. So now tell me, sir, this one, the temporal or the giant cell arteritis. The temporal or the giant cell arteritis, yes, it is a granulomatous vasculitis. Now what about this? What about Takayasu? It is also granulomatous. It is also granulomatous vasculitis. So both the large vessel vasculitis, that is temporal arteritis as well as Takayasu, temporal Takayasu, both are granulomatous vasculitis. Temporal arteritis, superficial temporal artery is involved. In Takayasu arteritis, the subclavian artery is most commonly involved. Done. Okay, done. So large vessel vasculitis are completed, sir. So now let's strike here. So these two are completed. Temporal, Takayasu completed. Now after that, we have to start with what? We have to begin with the medium vessel vasculitis. Just as a recap, in medium vessel vasculitis, what do we have? We have polyarteritis nodosa, Kawasaki disease, and thromboangiitis obliterans, also called as Berger's disease. Okay, Berger, not burger, Berger. Okay. Now, see, whenever I used to think about the medium vessel vasculitis, the three types of medium vessel vasculitis, first thing that will come to your mind, whenever I used to think about the polyarteritis nodosa, the first type in the medial vessel vasculitis, the polyarteritis nodosa, I used to think about this, plan B. So what is this plan B? Okay, we all have the plan B, right? Okay, if something goes wrong, plan A goes wrong, plan B, we all have the plan B. So what is this plan B? I used to remember something like this. This is my self-made mnemonic kind of thing. So PAN, polyarteritis nodosa. Multiple blood vessels are involved. Okay, like nodules, small nodules, blood vessels are involved. And then what is this B, sir? B. So this polyarteritis nodosa, this condition, it is associated with hepatitis B. The one vasculitis which is associated with the hepatitis B is PAN. So PAN B. I used to remember something like this. Plan B. Polyarteritis nodosa associated with hepatitis B surface antigen. Positivity will be seen. Hepatitis B surface antigen is positive in which type of vasculitis? Polyarteritis nodosa. Okay. Now look here. See what you are looking at here. So the inflammation is there, severe inflammation. So this is just not a granulomatous inflammation. This is a necrotizing inflammation. Necrosis. The tissue death is going to occur, sir. So it's a necrotizing vasculitis. Important points which you should know for your exam. So this, why it is occurring, we don't know the exact reason. Idiopathic. So it's an immune complex mediated vasculitis. True. Seen in whom? Seen in males, not in females. Seen in males, young males. Okay, not in female, I shouldn't say something like that. It's mainly seen in young males. See, 30% cases of the polyarteritis nodosa are associated with hepatitis B surface antigen. Okay, hepatitis B surface antigen is going to come positive. 30% of the polyarteritis nodosa, they are going to have surface antigen B positivity. Hepatitis B association. Plan B, same thing. Okay, and these patients are also associated with hairy cell leukemias. Okay, they are also associated with the hairy cell leukemias. Now, see here in this condition, the one important I want you to know. So PAN, right? Polyarteritis nodosa. PAN. Polyarteritis nodosa. Multiple blood vessels are involved. But one blood vessel is not involved, sir. One blood vessel is not involved. So what is that? Pulmonary arteries are not involved. Pulmonary arteries are not involved. I used to remember something like that. Okay, famous mnemonic, especially for the board exams, USML exams. So PAN means pulmonary artery not affected. All blood vessels are affected, but pulmonary blood vessels are usually spared. So that's the MCQ, sir. Pulmonary arteries are usually spared. What is the most common blood vessels which are involved then? Which blood vessels are involved most commonly? Renal blood vessels. Okay, so the renal blood vessels are most commonly going to be affected. Okay, renal blood vessels, the cerebral blood vessels are involved, but the renal blood vessels are most commonly involved. Okay, in this condition, polyarteritis nodosa, if you look at the kidneys, देखो how the kidneys are looking like. Sir, are you able to appreciate the small petechial, like small hemorrhages? Okay, these are nothing but flea-bitten appearance. So these kidneys are having flea-bitten appearance. So flea-bitten appearance is seen in which type of vasculitis? Polyarteritis nodosa. It is also seen in other vasculitis also, henostrol and purpura, but later we will discuss. Okay, in the next slide we will discuss. So tell me, what are the important points? How you should remember the polyarteritis nodosa? See, the mnemonic which I gave you is Plan B. Plan B for PLAN. Polyarteritis nodosa associated with hepatitis B. Hepatitis B. Also associated with hairy cell leukemia. Okay, done, sir. PAN. Polyarteritis nodosa, just remember it like pulmonary artery not involved. All blood vessels are involved, but pulmonary arteries are not involved. Then what are the most common blood vessels involved? The most common blood vessels that are involved are kidneys. Okay, the renal arteries are going to be most commonly involved. So because of the involvement of the kidneys, what kind of appearance is seen? Flea-bitten appearance is seen. Usually in this condition, there is no hematuria. Hematuria is not seen. Okay, nephritic syndrome, hematuria are not seen. Just what you are going to have is the flea-bitten appearance of the kidneys. Okay. Next, sir, is it a granulomatous vasculitis? See, I have told you in the beginning itself. See, it's not just a granulomatous vasculitis. It's a necrotizing. It's a necrotizing vasculitis. Necrosis is happening. Okay. So, see, necrotizing transmural inflammation. The entire blood vessels, there is a transmural. All the vessel wall, all the layers in the vessel wall are going to be affected. Transmural inflammation with the necrosis. Okay. So, even in the cell injury topic, I have explained you. So, in polyarteritis nodosa, there is fibrinoid necrosis. Okay, there is which type of necrosis? The blood vessels are dying. The blood vessels are dying, sir, necrotizing. Which type of necrosis? Coagulative, liquefactive, caseous. Which type of necrosis? Fibrinoid necrosis. Never ever forget this. MCQ. Okay. So, done, sir. Now, you can ask me, sir, why it is called as polyarteritis nodosa? Polyarteritis means multiple blood vessels are involved. Then what is that nodosa? See, if you look at this arteriogram, okay, this is the arteriogram which I am showing you here. Now, are you able to appreciate this, like, nodular appearance in the blood vessels? Okay, nodular appearance. So, this is something called as a string of bead appearance. Okay, this is something called as a string of bead appearance, a string of beads. So, that's why the name nodosa. like the small nodules. So polyarteritis nodosa. Okay, string of bead appearance is going to be seen. Okay, string of beads appearance. Renal arteries are going to be most commonly affected. Now, in your exams, especially in NEET-PG exam and FMG exams, they can ask you, sir, flea-bitten kidneys are associated with which conditions? Now you know, sir, flea-bitten kidneys are seen in which type of vasculitis? It's seen in polyarteritis nodosa, medium vessel vasculitis. Guys, do you have any other idea? So look here, malignant hypertension. So malignant hypertension is associated with flea-bitten kidney. I have taken it from the internet, but yeah, important. So malignant hypertension, polyarteritis nodosa, and look, even henoch-Schulin purpura. Okay, henoch-Schulin purpura we will discuss. This is also a vasculitis. Okay, here also you will see the vasculitis, henoch-Schulin purpura. Okay, henoch-Schulin purpura, infective endocarditis, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, rapidly progressive glomerulonephritis. You need to by heart them, sir. You need to by heart them. There is no doubt. So you can get an MCQ from here. Image based question they can ask you. Okay, image based question. See, that's a petechial appearance. Okay, on the kidney. Now tell me, flea-bitten kidneys are associated with, just answer whatever you can. Malignant hypertension, okay, hemolytic uremic syndrome, polyarteritis nodosa, henoch-Schulin purpura, rapidly progressive glomerulonephritis, infective endocarditis. Enough. If you can remember this much, it's more than enough, sir. Okay, done. After this, let's discuss about the next type of vasculitis. The next type of vasculitis. First, before that, now put a cross mark here. What we have completed? We have completed polyarteritis nodosa. Done. Now we have to discuss about Kawasaki diseases. Whenever I think about a Kawasaki disease, I used to think something like this. Okay, Kawasaki. What is that Kawasaki? Our favorite bike. Okay, boy's favorite. What is that? Kawasaki bike, right? See, Kawasaki Ninja bike. Okay, see, it's a Kawasaki bike, sir. Okay. Now there is a boy. Okay, there is a boy who is riding on this Kawasaki bike, but this boy is not a good boy. He's a naughty boy. Okay, bad boy. Why bad boy? Because he's having what? He's carrying something. What is that, sir? What he's carrying? It's a Corona beer. Okay. So now, whenever this boy, little boy, whenever he takes this Corona beer and whenever he goes on a ride with Kawasaki bike, what happens? Definitely there is going to be a crash. Immediately there is going to be a crash, sir. Okay, there is going to be a crash. So I used to remember something like this. Okay, I used to remember something like this. So, Kawasaki bike, a child with a Corona beer is going to have a crash. He's going to have a crash, sir. So he is now crying. He's crying. Crash. Okay. So now why I gave you all this story? A story kind of thing. Because see, so the Kawasaki disease. Look, let's write one by one point. So this Kawasaki disease, it's going to occur in whom? It's going to occur in 40 years or 50 years or 20 years? Young males and young females? No, it's going to be seen in children, sir. It's going to be seen in children. So it's a pediatric vasculitis. The first point is it's a pediatric vasculitis. Seen in whom? Small child, that is less than 4 years of age. Okay, less than 4 years of age. So why it is happening? No idea. No one doesn't know why it exactly happens. Okay, exactly why it's happening, no one don't know the idea. So this Kawasaki disease, also called as a mucocutaneous lymph node syndrome. Okay, mucocutaneous lymph node syndrome, sir. Which means the mucous membranes, the skin involvement will be there, mucous membranes, the skin involvement will be there, and the lymph node involvement will be there. Okay, mucosal membranes are going to peel off. I will show you, the mucosal membranes are going to peel off. There will be skin peeling, sir. And the lymph nodes are going to be enlarged. Lymphadenopathy is going to be seen. Lymphadenopathy. Okay. So one by one, let's discuss one by one. So, see, mucous membranes are going to be involved. That's why mucocutaneous disease, inflammation is going to be there. So, what's the diagnosis? Let me tell you something. How to put the diagnosis even before diagnosis. So, see, here I have shown you the children with that Kawasaki bike. See, why a child is riding this Kawasaki bike? It should remind you, it's going to occur for the children. Kawasaki disease is going to be seen in the children. Pediatric vasculitis, less than 4 years of age. Then why he is having this Corona beer? The Corona beer here stands for his coronary arteries, the most common blood vessel that is going to be affected. The most common blood vessel that is going to be affected is coronary arteries. Okay. Now, okay, sir. Well, now what happened? He's having a crash. So So what exactly this crash stands for? That's a diagnosis. That's for the diagnosis. Dekho, how to put the diagnosis of this Kawasaki disease? The patient is going to have, see, CRASH, right? CRASH, crash. See, conjunctivitis. The patient is going to have the conjunctivitis. Okay, bilateral, non-suppurative conjunctivitis. Okay, there will be a rash. Okay, polymorphous rash. Okay, polymorphous to desquamative. Polymorphous, just remember the rash. The patient is going to have the rash on the skin. Okay, next, adenopathy. CRA. C completed. Okay, C completed. R for rash, A for adenopathy, lymphadenopathy, lymph nodes are going to be enlarged. Next, S, strawberry tongue. Okay, if you look at the tongue, his tongue is going to look like a strawberry. Okay, strawberry because of the mucosal involvement. Mucositis, inflammation of the mucosa, mucositis. Okay, oral mucositis, hand-foot involvement. So what is this hand-foot involvement? There will be edema. Okay, erythema. Okay, skin involvement, right? Edema and erythema. The skin involvement, erythema. The hands are going to be reddish in color. Okay, so hand and foot involvement will be there. Edematous hands will be there. Okay, so this is crash, sir. C-R-A-S-H. Crash. And I have explained you what is the most common cause of death. The most common cause of death in this patient is coronary artery disease. Why coronary artery disease? The coronary artery disease is because of the involvement of the coronary arteries. The most common blood vessels that are involved are the coronary arteries. So coronary artery involvement can lead to myocardial infarction, and that myocardial infarction in such a small baby can lead to death. So when a small boy, if he is having myocardial infarction, then you should think about maybe that boy might be suffering with Kawasaki disease. Okay, coronary arteries are most commonly involved. So now look at this image. What are the points which you need to know? See, dekho here, the boy is having a rash, and hand and foot involvement, sir. See, the skin is peeling off. Okay, so the skin is peeling off, the skin and the hand involvement, hand and foot involvement. Now, if you look at the eyes, there is bilateral conjunctivitis, red color conjunctivitis. Now, what is this? Oral mucositis. The mucus, the layer, the mucosa is going to peel off. And here you can very clearly see the lymphadenopathy. Okay, the lymph nodes are going to be enlarged. In the small boy, the lymphadenopathy is seen, sir. And strawberry tongue. So now, come on, just a recap of Kawasaki disease. First, Kawasaki disease. Kawasaki disease is a type of medium vessel vasculitis, large vessel vasculitis, or small vessel vasculitis. It's an example of medium vessel vasculitis. Done. What you should think, a small boy with a corona beer is going on a Kawasaki bike, made a crash. So from this story, what you should know, sir, seen in children, pediatric vasculitis, less than 4 years of age. Okay, most common blood vessel involved, coronary arteries. Most common cause of death, myocardial infarction. How to put the diagnosis? The diagnosis, how we can establish the diagnosis is, sir, I have shown you 5 features, CRASH. Out of these 5 features, if you have any 4 of the following, okay, okay, fever plus any 4 of the following, what are those 5? CRASH, C for conjunctivitis, R for rash, A for adenopathy, lymphadenopathy, S for strawberry tongue, oral mucositis, and H for hand and foot involvement. Answer. Done. Now, if you take the blood sample from these fellows, okay, so what you can find in the lab is, so these patients are going to have anti-endothelial antibodies. Okay, anti-endothelial antibodies are going to be seen in these persons. Okay, anti-endothelial antibodies are going to be seen. Done, sir. So Kawasaki is also completed. So let's put a cross mark for the Kawasaki. Ho gaya. Done. We are done with the Kawasaki. Now next disease is thromboangiitis obliterans. The name itself is there. They go thrombus. Angiitis, inflammation of the blood vessels, and obliterans. The blood vessel is going to be obliterated, completely blocked. Okay. So now the blood vessel is completely blocked. There's going to be ischemia, followed by infarction followed by total necrosis. So let me show you. So they go here. Now what is this, sir? What you are able to see here? The patient is having amputation of his fingers, auto amputation of the fingers. Why? Because the blood vessel supplying this area is totally blocked. The blood vessels are blocked because of the thrombus. So thromboangiitis obliterans. There is infarction leading to necrosis. This is dry gangrene, right? Dry gangrene because of decrease in the blood flow. Arterial occlusion. This is called as auto amputation. Very, very important MCQ. Auto amputation of the fingers is seen in which type of vasculitis? It is seen in thromboangiitis obliterans, also called as Burgess disease. In whom you will see this? In whom we will actually see this, sir? See, dekho, it is seen in heavy smokers. We will go one by one. So, thromboangiitis obliterans, also called as a Burgess disease, seen in young. Why? Because young people are the ones who smokes most. Okay, young people. So, 35 years. Okay, heavy smokers are seen in heavy smokers. It is associated with what? Associated with something called as Raynaud's phenomena. Raynaud's phenomena, sir. So, this is what is the Raynaud's phenomena. See, this area became pale. Okay, this area became pale. Why? Because the blood supply got lost. Okay, associated with the Raynaud's phenomena. To that area, the blood supply is lost, so it becomes pale. Okay. Okay, done, sir. Now, what are the clinical features? So, these patients are going to have intermittent claudication, intermittent pain because the blood supply is decreasing. So, now very, very important point. If in a question, if they mention you, see, jaw claudication is the most specific sign seen in temporal arteritis or giant cell arteritis. Okay. But here in thromboangiitis obliterans, the patients are going to have intermittent claudication. Okay. So, when he is walking, he is going to have a severe pain. When he takes rest, again, pain is going to be subsided. Okay. So, intermittent claudication, that is going to be relieved with rest. Okay. Now, what else I want you to know here is, so, look, in this one condition, in this one type of vasculitis, thromboangiitis obliterans, inflammation is there, thromboangiitis. Angiitis means inflammation of the blood vessels. Which blood vessels? Arteries or veins? See, dekho, so, here the arteries are going to be affected. There is inflammation of the arteries, true. There is inflammation of the veins. So, veins can be blocked with thrombi. Okay, the arteries can be obliterated. Okay, arteries can be obliterated. Veins can be obliterated. And what happens in this condition is the entire neurovascular bundle, that is arteries, veins and nerves, all these three are going to be affected with inflammation. Arterial inflammation, arteritis. Okay, even the veins are going to be affected with inflammation, as well as this inflammation even spread to the surrounding nerves. So, the entire neurovascular bundle is affected, but MCQ in your exam, the lymphatic blood vessels are usually spared. The lymphatics are not affected, sir. Lymphatics are not affected. So, as a doctor, we need to clear the exam. First, that's our primary motive. So, what we need to know? See, simple. Thromboangiitis obliterans, medium vessel vasculitis, also called as Burgess disease, associated with heavy smokers, seen in heavy smokers, young males 35 years of age, associated with Raynaud's phenomena, Okay, there will be blanching. Okay, that's the Raynaud's phenomena, sir. So, in which type of vasculitis the entire neurovascular bundle is affected? That's the arterial involvement, veins involvement, as well as the nerve involvement. That is the thromboangiitis obliterans. Okay, lymphatics are affected. Lymphatics are usually spared. And what you will see, there is auto amputation of the fingers. You can very clearly see here, this is a blood vessel. Okay, the apse of the blood vessel. So, the entire lumen is blocked with the thrombus. This is a thrombus. Okay, with lot of infection as well as inflammatory. See, the lot of inflammatory cells are seen. Okay, see, demonstrate a vessel completely occluded by inflammatory thrombus. Okay, and even you can see the micro abscess. Okay, infection, micro abscess. Okay, so done. Is that okay? Now shall we have a recap? Just a recap. Important topics. Okay, now just close your eyes. Tell me, how many types of vasculitis are there? Just how many types of vasculitis are there? 3 types of vasculitis. Okay, 3 types of vasculitis are there. What are they? Large vessel, medium vessel and small vessel vasculitis. Okay, so vasculitis are associated with which type of antibody? So vasculitis are associated, especially small vessel vasculitis are associated with ANCA antibodies. How many types of ANCA are there? There is P ANCA and C ANCA. Okay, P ANCA and C ANCA, sir. Done. Next, P ANCA and C ANCA completed. Next, what are the 2 types of large vessel vasculitis? The 2 types of large vessel vasculitis are temporal arteritis or giant cell arteritis, also temporal arteritis, giant cell arteritis and Takayasu arteritis. Which disease is called as pulseless disease? Takayasu arteritis. Okay, both the temporal and Takayasu, they are granulomatous vasculitis. Both are granulomatous vasculitis. Now, which vasculitis which we have studied now so far is a necrotizing vasculitis? Sir, necrotizing vasculitis is polyarteritis nodosa. Polyarteritis nodosa is an example of necrotizing vasculitis. So it's a necrotizing vasculitis. Okay, which type of necrosis? Fibrinoid necrosis. Fibrinoid necrosis. Okay. Next. So in Kawasaki disease, what is the most common blood vessel that is affected? Coronary arteries are affected. So what is the most common cause of death? Myocardial infarction. Myocardial infarction in such a young boy. What are the clinical features that are seen? CRASH, crash. CRASH, crash. Conjunctivitis, rash, adenopathy, strawberry tongue, and hand and foot involvement. Hand and foot involvement. Which antibodies are seen? Anti-endothelial antibodies are seen in Kawasaki disease. Okay, done, sir. Now, in which type of vasculitis? We have studied about flea-bitten appearance of the kidneys. The flea-bitten appearance of the kidneys are seen with polyarteritis nodosa. Polyarteritis nodosa. Okay, done, sir. Done. Other amputation is seen with Burgess disease. Burgess disease is also called as thromboangiitis obliterans, associated with Raynaud's phenomena, seen in heavy smokers. Okay. Now, after this, let's discuss about the small vessel vasculitis. Now, we are going to start with the small vessel vasculitis. Now, look here, what is small vessel vasculitis? First small vessel vasculitis that we are going to discuss. The first small vessel vasculitis that I am going to discuss is Wegener's. Okay, Wegener's granulomatosis. Okay, Wegener's granulomatosis. Now, I have asked you to remember Wegener's granulomatosis as Wegener's. Okay, Wegener's. Why? Why Wegener's? C-ANCA positivity is seen. C-ANCA, 75% of the cases. Okay, 75% of the cases are associated with the C-ANCA. Remember that. We will discuss about that later. Now, one by one. So, this Wegener's granulomatosis is also called as granulomatosis with polyangiitis. True. The granulomatosis with polyangiitis. This is also same. Not only polyarteritis nodosa. This is also necrotizing vasculitis. So, tell me two necrotizing vasculitis. One is polyarteritis nodosa and Wegener's granulomatosis. Wegener's granulomatosis is also called as granulomatosis with polyangiitis. Now, in the name itself, it said, dekho, granulomatosis. So, it is granulomatous vasculitis along with necrotizing. Granulomatous vasculitis. Inflammation is granulomatous inflammation. But at the end of the day, necrosis is happening. The blood vessels will undergo necrosis. The tissue will undergo necrosis. Okay, so necrotizing vasculitis as well as granulomatous. Both true. Now, in this vasculitis, which organs are most commonly affected? Very important MCQ, sir. 3 organs are going to be most commonly affected. Nose, lungs and kidneys. Okay, nose, lungs and kidney involvement is going to be seen. Nose, lungs and kidneys. See, lungs and kidneys are affected, sir. Now, if my lungs are affected, okay, because of this vasculitis, I will be having hemoptysis. When I am coughing, I will be having hemoptysis. Blood is going to come out in the cough. And when my kidneys are going to be affected, I am going to have the hematuria, blood coming out in the urine. So these patients are going to have hemoptysis with hematuria. Hemoptysis with hematuria, sir. This is the same hemoptysis and hematuria also seen in Goodpasture syndrome. There is a lung pathology we will study. Hemoptysis and hematuria. Whenever you see this combo, sir, hemoptysis and hematuria, 99% of the students will think about Goodpasture syndrome. They will think about the Goodpasture syndrome. But not only Goodpasture syndrome, even in this Wegener's granulomatosis also, lung involvement will be there and kidney involvement will be there. And nose involvement also. So what are the clinical features? We'll discuss one by one. Look at this, clinical features. So the nose involvement, nose and the paranasal sinus is also involved. Nose and the paranasal sinus is involved. So these patients are generally going to have the runny nose. Okay, runny nose. There is a rupture of the nasal septum because of the vasculitis. The nasal septum, the nasal bridge, the nasal septum, not bridge, the nasal septum is going to be going to have the necrosis in the nasal septum, going to form the perforation, going to have the perforation. So there is rupture of the nasal septum leading to perforation. Rupture of the nasal septum, true. Runny nose is going to be there, and chronic sinusitis, sinus involvement leading to chronic sinusitis. Okay, these are all the nose and paranasal sinus involvement. Apart from this, also I have explained to you. So there is hemoptysis, lung involvement. Okay, hemoptysis. Kidney involvement is, see, dekho, hematuria, hemoptysis and hematuria. You can ask me why hematuria, sir. See, imagine I am the patient who is suffering with, I am the patient who is suffering with Wegener's granulomatosis, sir. I am the patient. Okay, example I am giving you. I am the patient who is suffering with Wegener's granulomatosis. Now, I will develop rapidly progressive glomerulonephritis or crescentic glomerulonephritis. Glomerulonephritis, inflammation of the glomerulus. What is glomerulus? Glomerulus is nothing but the blood vessels. Okay, these blood vessels only. So if I have Wegener's granulomatosis, my kidneys are going to have the nephritic syndrome. Nephritis, glomerulonephritis is going to be there. Okay, so that's why, yeah, these patients are going to have crescentic glomerulonephritis or rapidly progressive glomerulonephritis. That is the one causing hematuria. Whenever there is hematuria, RBCs are coming out in the urine. So in the urine you can see RBC casts. Okay, RBC casts, sir. So now tell me, what are the important points about the Wegener's granulomatosis? Remember it like Wegener, C anchor positivity, small vessel vasculitis. Three organ systems are going to be involved. Nose and paranasal sinuses involved, leading to runny nose and chronic sinusitis. Lung involvement is going to show hemoptysis, cough and dyspnea will be there. Hemoptysis is important. And kidney involvement, that is the chronic, not chronic, sorry, it's the crescentic glomerulonephritis or rapidly progressive glomerulonephritis is going to be occurring in the kidneys that will lead to hematuria with RBC casts which are seen in the urine. Done, sir. Now if you look at this, patients with the Wegener's granulomatosis, they are going to have saddle nose deformity. Saddle shaped nose is going to be there. Okay, saddle, you know, right? On the horse back you are going to have a saddle. You are going to sit on that saddle. Okay, so like that. Saddle nose is going to be there. And if you look at their gums, okay, if you look at their gums, they will be having strawberry gums, strawberry gingivitis, strawberry gums. Wait, where we have studied about the strawberry, tongue? Come on guys, tell me where we have studied about the strawberry tongue. It's a Kawasaki disease, strawberry tongue. But here what you are saying, this is not the strawberry tongue, this is strawberry gingivitis, strawberry gums, because of the inflammation of the blood vessels. Now can you tell me where you will see the strawberry vagina? The strawberry vagina is seen in, or the strawberry cervix. Okay. In which condition, sir? Strawberry vagina, sir. An angry looking cervix. We'll call it as an angry looking cervix. One more name is there, which is also called as Culpitis macularis. Okay, Culpitis macularis, strawberry vagina or strawberry cervix, it is seen in Trichomonas vaginalis. Okay, so there is an infection called as trichomoniasis. Okay, in trichomoniasis, there is going to be strawberry cervix. Okay, done. So, in Wegener's granulomatosis, necrotizing vasculitis, granulomatous vasculitis, small vessel vasculitis, nose, lungs, kidney involvement, hemoptysis with hematuria, saddle nose deformity will be seen, as well as strawberry gingivitis, sir. Okay, done. Now, देखो, so in one of the PG exam, this question was asked, what is the Wegener's triad? In Wegener's granulomatosis, there are the triad of symptoms. What are the triad of symptoms? Yes, vasculitis is there, small vessel vasculitis is there, true. Upper respiratory tract and lower respiratory tract infections can be there. Okay, respiratory tract is chronic sinusitis because of the upper respiratory tract infection. Okay, and lower respiratory tract infection can lead to hemoptysis and glomerulonephritis. I have discussed rapidly RPG and rapidly progressive glomerulonephritis, also called as crescentic glomerulonephritis, leading to hematuria. So these are the three things which are present in the triad. So Wegener's triad include vasculitis, small vessel vasculitis with upper and lower respiratory tract infections and glomerulonephritis. Kidney involvement, lung involvement and vessel involvement. Wegener's triad. See, question which I want you to know is, what is the treatment for this one condition, sir? Okay, this is something really very important. So what is the treatment? Guys, do you have any idea what is the treatment in this condition? It's a cyclophosphamide, sir. It's a drug. So cyclophosphamide is a treatment that we is a drug which we use for the treatment of Wegener's granulomatosis. But whenever you use pharma integration, whenever you use the cyclophosphamide, what's going to be the side effect? What's going to be the side effect, sir? The side effect is going to be hemorrhagic cystitis. Hemorrhagic cystitis. Okay, they're going to be hemorrhagic cystitis. Inflammation of the bladder, urinary bladder. Okay. Now let me tell you why exactly it happens is, so if you give cyclophosphamide or ifosfamide, say ifosfamide or cyclophosphamide, you are giving it, sir. You are giving the drug. Now in the body, this is cyclophosphamide and ifosfamide, these are the drugs. Remember, same cyclophosphamide, okay, and ifosfamide here. Cyclophosphamide and ifosfamide, they are going to be broken down. Okay, they are going to be broken down in our body, sir. Into what? Into a substance called as acrolein. This is MCQ. So the cyclophosphamide, whatever you have given, the cyclophosphamide is going to be broken down into a substance called as acrolein. Okay, in the body, it is something toxic to our body, sir. It's a toxic metabolite. Okay, it's a toxic metabolite. What it will do is, this acrolein, it will cause irritation to the bladder. It will cause irritation to the bladder. So the bladder is getting inflamed and it is bleeding, sir, now. Okay, it's bleeding. There is inflammation followed by bleeding. So bleeding. So cystitis, hemorrhagic. Okay, hemorrhagic means bloody urine. Okay, bloody urine is going to come out. Hemorrhagic cystitis, inflammation of the bladder. Because of what? Because of the acronin. Acronin is the byproduct, or acronin is the metabolite of cyclophosphamide or ifosfamide. Done. Okay, done, sir. So Wegener's granulomatosis is also completed. Important point we have forgot. What is that? 75% of the cases are associated with C and K, and 25% of the cases are associated with P and K. C and K and P and K, sir. Done. Now after this, let's discuss about microscopic polyangiitis. Microscopic polyangiitis. See, this microscopic polyangiitis, again, small vessel vasculitis, true. Okay. It is also called as microscopic pan. This is microscopic polyangiitis. Right now I am talking about microscopic polyangiitis. But what is the other name? The other name is called as microscopic pan. Microscopic polyarteritis nodosa. Okay. So, aka microscopic pan. One more name is there. It is also called as leukocytoclastic vasculitis, MCQ. So, what are the three names? Microscopic polyangiitis, or microscopic pan, or leukocytoclastic vasculitis. Okay. Now, what are the differences? Okay, what are the differences between pan, that is polyarteritis nodosa, the medium vessel vasculitis, and the microscopic pan, that is microscopic polyangiitis? What are the differences? Dekho, microscopic pan and pan. What are the differences? See, in pan, the P and K is negative, sir. P and K is negative. There is no such thing as anchor in pan. But here in microscopic polyangiitis, in the beginning I have explained you. In microscopic polyangiitis, the P and K is going to be positive. Okay, the P and K is going to be positive, sir. One is a medium vessel vasculitis, the other is a small vessel vasculitis. Okay. So now, third thing which we are going to discuss. Sir, even this is an example of, it is also going to cause fibrinoid necrosis. Where we have seen the necrosis? We have seen the necrosis 3 places so far. Okay, with this. What are they? Polyarteritis nodosa, Wegener's granulomatosis. Wegener's is also an example of necrotizing vasculitis, and microscopic polyangiitis or microscopic pan. Microscopic pan is also an example of fibrinoid, is going to cause the necrosis, fibrinoid necrosis, sir. Okay, but this is non-granulomatous. It's non-granulomatous. No granulomas are seen. Okay. Now, important point. See, very important. Both pan and microscopic pan. Okay, both polyarteritis nodosa and microscopic pan. Microscopic pan means microscopic polyangiitis. Both these are non-granulomatous. Both are non-granulomatous. Both are non-granulomatous. There is no granuloma formation. Okay, and in this microscopic pan, there is going to be fibrinoid necrosis. Now, even in this condition, microscopic polyangiitis, lungs and kidneys are going to be involved. Lungs and kidney involvement, sir. Okay, lungs and kidney involvement. So even in this condition, the patient is going to have hemoptysis and hematuria. Okay, so hemoptysis and hematuria are seen in Wegener's granulomatosis. Hemoptysis, hematuria is seen in Wegener's granulomatosis. Even in this microscopic polyangiitis, again hemoptysis and hematuria are seen. But how to differentiate? There are many features. See, in Wegener's granulomatosis, the patient is going to have they will give you in your question saddle-like deformity. They will give you the gingivitis, the strawberry gingivitis. They can explain you, and the patient is going to have the chronic sinusitis. Okay, chronic sinusitis, or the cough is going to be there. So there are multiple things which they can add you. They can say something like there is presence of the C and K in the blood. So you can differentiate, sir. Based on the other features, you should differentiate, because both in Wegener's granulomatosis as well as microscopic polyangiitis, in both the conditions, hemoptysis and hematuria are seen. After this, look here and tell me, sir, what you are looking at here? Just image what you are looking at here. Sir, you can very clearly see the purpura, sir. These are the bleeding. Okay, these are the bleeding spots. There is skin bleeding, sir, bleeding into the skin. So these are the purpura. You can palpate them also. You can actually palpate them. Okay, they are little elevated, so you can actually palpate them. They are the palpable purpura, sir. So my question to you, sir, is this a small kid or an adult? Whatever I am showing you, see, he is wearing a small, small diaper kind of thing. Okay, this is definitely a child. Okay, so now let me write one by one important point. The condition which I am going to discuss here, it is called as Henoch purpura. Okay, Henoch swollen purpura. What is the other name? Also called as anaphylactoid. Okay, anaphylactoid purpura. Okay, anaphylactoid purpura. Okay, anaphylaxis. Okay, anaphylaxis. Okay, means allergy. Anaphylaxis, allergy. See, this is the most common MCQ. Most common vasculitis in children. So now you know two types of vasculitis that can come in children. One is the most common vasculitis that can come in children is swollen purpura, sir. Swollen purpura. And also we have discussed the Kawasaki disease. The Kawasaki disease is also going to occur in a child less than 4 years of age, the coronary artery involvement. Okay, so the most common vasculitis in the children is swollen purpura. What happens here is, sir, the IgA antibodies. Okay, the IgA antibodies are going to deposit in vessels. Okay, so there will be high levels of IgA antibodies. There is high level of IgA antibodies that are getting produced in the body. These IgA antibodies, they will start to deposit in the blood vessel, leading to inflammation. Okay, the vessels are now going to start the inflammation, sir. Now, what are the clinical features? These patients. So, what are the clinical features that these patients are going to have? See, I used to remember like HSP. There is a mnemonic, sir. HSP. swollen purpura. HSP will be hinge pain. What is this hinge pain, sir? Hinge, like you know the thing, right? Hinge means joints, hinge joint, a type of synovial joint. So that is arthralgias. Okay, arthralgias, sir. Okay, hinge joint. Okay, arthralgias, pain in the joints. Yes. What is this S for? The patients are going to have stomach pain. Stomach pain. So why stomach pain? Because these patients, they will develop into susception. Okay, intussusception. I hope you already know what exactly is intussusception. If you don't know, just Google it and check later. Intussusception means one part of intestine, it will go into the other part of intestine. This is something called as a telescoping. You know the telescope, right? When you just take out the telescope, okay, one part will insert in the other, like you know the telescoping thing. So in the same way, one part of the intestine, it will herniate into the other part. This is called as intussusception. So which type of vasculitis is associated with intussusception? It is swollen purpura. So the patients are going to have arthralgias, intussusception, and last P for palpable purpura. Okay, palpable purpura are going to be seen, sir. See, this purpura is not because of deficiency in the platelets. See, if there is a deficiency of the platelets, definitely there will be bleeding into the skin. Okay, that's a total different thing, sir. This is not because of the deficiency of the platelets. This bleeding is not because of the platelets. This palpable purpura are not because of the platelet problem. This is because of the vasculitis. The blood vessels are getting inflamed. The blood vessels are undergoing damage. That's causing the leaking of blood into the skin. That's what's causing the purpura. Okay. So purpura, it is because of vessels, inflammation of the vessels, not because of the platelets. Okay, not because of the platelets. Next, what else you will see? So, image based questions, palpable purpura on the buttocks, they will give you. Many of the exams, especially in the USMLE exams, they will give you this palpable purpura on the buttocks in a child. What is the diagnosis? Swollen purpura, most common vasculitis in the children. Okay, it's also a pediatric vasculitis. Okay. Now, what you will see, sir, in these patients, lab diagnosis. Okay, in the labs, there will be thrombocytosis, which means the platelet levels are going to be elevated. Why? Because they are having more and more bleeding. To make the blood clots, the platelet count is going to be increased. Thrombocytosis, sir. Okay, not the thrombocytopenia, it's the thrombocytosis is going to be seen. Not only that, second thing, they are going to have elevated levels of IgA antibodies. High levels of IgA antibodies. High IgA antibodies are there. That's the problem. That's IgA antibody deposition in the vessels is causing the inflammation in the vessels. That's causing the vasculitis, sir. Okay, done. So swollen purpura is also completed. What we have completed in the small vessel vasculitis? In the topic of small vessel vasculitis, we have done with the Wegener's granulomatosis. We have completed microscopic polyangiitis, also called as microscopic pan. Now we have completed the swollen purpura. Next, we'll discuss about Church-Strauss syndrome. Okay, Church-Strauss syndrome, sir. What are the important points which you should know regarding the Church-Strauss syndrome? Church-Strauss, do you have any idea? It's also called as allergic granulomatosis with polyangiitis. Important. Okay, allergic. This is the keyword, sir. Which type of vasculitis is associated with allergy? Church-Strauss syndrome. Allergic. Okay. So allergic granulomatosis with polyangiitis. So in these patients, okay, all the allergy symptoms are going to be seen. So usually the clinical features in these patients are going to be rhinitis. Okay, there will be allergic rhinitis. That's a cold. So allergic rhinitis is going to be seen, and it's also associated with other allergies like allergic asthma. Okay, allergic asthma is going to be seen, and so if I am the person, okay, who is suffering with allergies, actually in reality I am having the allergies. Okay, now if you take my the complete blood picture, you will be seeing eosinophilia. Okay, I have high levels of eosinophils in my blood. Okay, so even in this patient, the Church-Strauss syndrome, it's a allergic vasculitis. All right, so the eosinophils are going to be more hyper eosinophilia. Okay, so there will be hyper eosinophilia. So the eosinophil levels, the eosinophil count is going to be more. So peripheral eosinophilia is going to be seen, allergic asthma is going to be seen, allergic rhinitis are going to be seen. Okay, so it's a small vessel vasculitis associated with the allergies. Done. Now one MCQ, what is the most common cause of death? Any idea, guys? Most common cause of death? So this eosinophilic infiltrate. Okay, these eosinophils, they will infiltrate. Who infiltrate? Eosinophils. Eosinophils infiltrate the heart's myocardium. So there will be congestive heart failure. That can lead to congestive heart failure, and that's the cause of death. So the most common cause of death in Church-Strauss syndrome is congestive heart failure. Done. So with this, all the types of vasculitis are completed. Now, just the summary, sir. Let's see a summary. Summary of the vasculitis. Important point, large vessel vasculitis includes giant cell arteritis and tachyarteritis. Giant cell arteritis, more than 50 years, arteries of the head, that's that superficial temporal artery that is affected, sir. And in tachyarteritis, females are affected, less than 40 years of age. This tachyarteritis is also called as a pulseless disease. What is the most common blood vessel affected? That is the subclavian artery. The medium vessel vasculitis includes 3: polyarteritis nodosa, Kawasaki disease, and thromboangiitis obliterans, also called as a Berger disease, not Burger. Here it is wrongly, it's a mistake. Okay, this is Berger. Okay, B-U-E-R, Berger. Okay, so Berger disease. See, polyarteritis nodosa, young adults, widespread. See, polyarteritis, it, associated with hepatitis B, hairy cell leukemia. Pulmonary arteries are not affected. Necrotizing vasculitis. Most common blood vessels involved are the kidneys. Renal arteries are going to be most commonly affected. Sir, Kawasaki disease, less than 4 years age. Coronary artery disease is going to be seen. Coronary arteries are going to be affected. Lymphadenopathy is going to be seen. Mucocutaneous lymph node syndrome. And Berger disease, males, chronic smokers, extremities will show Raynaud's phenomena and auto amputation. Now, small vessel vasculitis, Wegener's. I have asked you to remember it like Wegener. C ANCA positivity is going to be seen. Lung and kidney involvement. Nose, lung, kidney. Saddle nose deformity is going to be seen. And strawberry gingivitis. Done. Church-Strauss is allergic. Eosinophilia, peripheral eosinophilia. Asthma is going to be seen. Rhinitis is going to be seen. Most common cause of death is congestive heart failure. Okay, lung involvement, eosinophilia, asthma, P ANCA. Okay, Church-Strauss, in the beginning we have discussed associated with the P ANCA, sir. Okay, and microscopic polyangiitis. Microscopic polyangiitis is also called as microscopic pan. Non-granulomatous, necrotizing vasculitis. Even in this condition, lung and kidney involvement will be there. Okay, lung and kidney involvement and P ANCA positivity. Okay, P ANCA positivity is going to be seen, sir. Done. So with this, all vasculitis are completed. All the vasculitis are completed, sir. Okay. So now after this, guys, shall we take a break of 5 minutes? Okay, shall we take a break of 5 minutes and shall we continue with the other topics in the vascular pathology? Important topics, sir. Very important topics like atherosclerosis, the vessel tumors. Okay, very much important for the NEET PG exams. So other topics which you need to know for your exams are the blood vessel tumors. The tumors of the blood vessels, sir. Okay. So vascular tumors. There are 3 types of vascular tumors. What are they? Benign tumors, intermediate risk, intermediate risk means risk for the cancer. Okay, there is a chance that these intermediate tumors can turn into cancers. There is a chance they can turn into cancers, sir. And malignant, the high risk malignant. Not just high risk, they are malignant, so they are the cancers. So benign tumors are there, intermediate tumors and malignant tumors. Malignant tumors are the cancers. Now what are the benign tumors that you need to know? So first one is capillary hemangiomas. First one. Second one is cavernous hemangioma. And third one, glomangioma. So there are 3 types of benign tumors. What are they? Capillary hemangiomas, cavernous hemangiomas and glomangiomas. There are 3 types. Okay. So all these are benign tumors. They are not the cancers. They are not the cancers. Image based questions are very important. I will show you. So the intermediate risk tumors are Kaposi sarcoma. Kaposi sarcoma. Okay, Kaposi sarcoma. And malignant tumors, malignant means cancer. It's absolutely cancer. The cancer of blood vessel is called as angiosarcoma. Okay. Angiosarcoma. Okay, angiosarcoma, sir. Okay. So these are the 3 types of tumors which we have to study now. Capillary hemangioma, cavernous hemangioma, glomangioma, Kaposi sarcoma and angiosarcoma. Now look at here. So the first type which we are going to discuss here is capillary hemangiomas. So capillary hemangiomas. Now image based question they will give you. A child. Now they go. He is having this. First of all, okay, I have seen many children, even in my family, they have this capillary hemangiomas. My question to you, so this is a blood vessel tumor, sir. This tumor is actually made up of what? This tumor is actually made up of the blood vessels. Sir, all these are the blood vessels, sir. My question to you, so this capillary hemangioma, okay, a type of capillary hemangioma called as strawberry hemangioma. Okay. So now tell me, sir, are they going to persist throughout the life? Or are they going to regress? My question to you, what do you think? So are they going to persist throughout the life or are they going to regress? They will regress, sir. They will regress. Okay. So important points. What are the most common site? The most common site is the skin. Okay, most common site is the skin and mucous membranes. They are non-capsulated tumors. They are non-capsulated tumors. They will start regressing. They will start regressing by the age of 1 year and they will completely regress by 7 years. Okay, these are all the MCQs, sir. They are regressive in nature. They are not going to persist throughout the life. They will start regressing by 1 year and completely they will regress by 7 years. Okay, 7 years of age. And image based question also. See, when you take a biopsy from that tumor, that capillary hemangioma or the strawberry hemangioma, now you can very clearly see these are the blood vessels, sir. These white spaces, what exactly are they? These are the blood vessels. How can you ask me? You can ask me, how can you say that these are the blood vessels, sir? See, these are the blood vessels because inside them, are you able to appreciate they are the RBC, very clearly seen, right? They are the RBCs, sir. Okay, so these are the blood vessels with lot of RBCs, blood cells. Okay, so done. Now after this, they go, what is this, sir? The next type of benign tumor that we are going to discuss are cavernous hemangiomas. Okay, cavernous hemangiomas. Okay, now point number 1. So these cavernous hemangiomas, are they going to regress? Are they going to, yes, of course they are benign, no doubt. Are they going to regress? Do not regress. Do not regress. Okay, they do not regress, sir. They are not going to regress. Next thing is, sir, this cavernous hemangiomas, how to identify them, how to differentiate them from capillary hemangiomas based on the histology. Look here, so this is a blood vessel. Okay, this is a blood vessel, sir. So these blood vessels are highly branched. Okay, the blood vessels are highly branched, sir. Okay, these blood vessels, they are highly branched. Okay, here they are not like this. They are the proper blood vessels, now nice and round blood vessels. Okay, so here also you can very clearly see on biopsy, you can see highly branched blood vessels. Okay, so this is one thing, sir. Now let me write one by one important point. They do not regress, and they are again non-capsulated tumor. They are non-capsulated tumors. There is no capsule around them. There is no such thing as a capsule. What are the most common sites? Bone and skin. See, even the capillary hemangiomas are also going to occur in the skin. But here something important: skin, liver involvement will be seen, sir. So even in liver, this cavernous hemangiomas can be seen, and even in the central nervous system. So organ involvement. Most common sites are skin, liver, and central nervous system. MCQ: skin, liver, and central nervous system. These are the MCQs. Now, one important point about the cavernous hemangiomas is, guys, can you tell me? So this cavernous hemangiomas, okay, of course, you know it, they do not regress. They are associated with, okay, they are associated with which condition? They are associated with von Hippel-Lindau syndrome. They are associated with the von Hippel-Lindau syndrome. Again, MCQ. CNS involvement, liver involvement, von Hippel-Lindau syndrome, they do not regress. How to identify them? See, there is branching, extensive branching of the blood vessels. Okay, you can say these are the blood vessels, because see, very clearly RBCs are seen. So the blood vessels are going to be extensively branched. Branching of the blood vessels are going to be seen. Okay, branched blood vessels. So they are associated with the von Hippel-Lindau syndrome. Now you can very clearly see here, von Hippel-Lindau is very, very important for your exam. See, in von Hippel-Lindau syndrome, the patients are going to have multiple tumors in the body. Okay, not one thing, multiple tumors in the body, sir. What is the mnemonic? CARPEEP, C-R-P-E-P, CARPEEP. What is this CARPEEP, sir? So, देखो, cerebellar hemangioma, देखो, hemangioma, central nervous system involved, hemangiomas, cavernous hemangiomas, okay, in the cerebellum, cerebellar hemangiomas, retinal angioblastoma, renal cell carcinoma, PEEP4, pheochromocytoma, all these are the tumors, ependymal tumors, endolymphatic sac tumors, pancreatic tumors. So in von Hippel-Lindau syndrome, one point I want you to know is that von Hippel-Lindau syndrome is associated with the hemangiomas. Okay, which hemangiomas? Cavernous hemangiomas. They do not regress. Most common sites are skin, liver, and central nervous system. Do not regress. Highly branched blood vessels are seen on the biopsy. Okay, associated with VHL, von Hippel-Lindau syndrome. This is not important. Next, the third type of tumor is glomangioma. I have explained you. Glomangioma, sir. See, what is this glomangioma? See, under your nail bed, under your nail, actually there is something called as a glomus body. There is something called as a glomus body, sir. It's a arteriovenous, like, you know, anastomosis. There is directly artery is going to meet with the vein. Okay, there is something called as arteriovenous anastomosis under our nail bed. Now here, this arteriovenous anastomosis, it's forming a structure called as glomus body. So glomus body is present under our nail bed. If you have a tumor, okay, if you have a tumor to this glomus body, then it is called as glomangioma. Okay, so glomus body is present under our nail bed. What is the function of this glomus body? Thermoregulation. MCQ. Glomus body, thermoregulation. Okay, thermoregulation. If you are having a tumor of that, okay, if you are having a tumor under your nail bed, very painful conditions, are very painful tumor, that is called as a glomangioma. Okay, actually here you can see the tumor. This is a tumor, sir. Actually there is a tumor. If you take out the nail, actually there is a tumor present here. That is glomangioma. Okay. Now, important points what you need to know for your exam is, so what is the most common site? The most common site is nail bed. It's a painful condition, it's a very painful condition. Okay, it's a very painful condition. Sir, from where this tumor is originating? Origin. Glomus body. Sir, what exactly is the function of glomus body? Thermoregulation. And what exactly is glomus body? It's arteriovenous anastomosis. Now, it's also a blood vessel tumor, right? It's also a blood vessel tumor. So look here. What you can see, sir. Okay, how you can appreciate the histology, how you can identify. So these are all the blood vessels. Dekho, this is a blood vessel. Okay, this is a blood vessel. How can we say these are the blood vessels? You can very clearly see RBCs are inside them. So definitely this is a blood vessel tumor of the blood vessels. Now, important point is, look, sir, in the wall, okay, in the septa, in these blood vessels, are you able to appreciate these blue color dots? These blue color dots, sir. Are you able to appreciate these dots? Everywhere they are present, dekho. But have you seen such kind of dots here? There is no such thing. Monomorphous dots are not there. Okay. See, somewhere like little dots are there, but extensively they are not present. Even here, they go. In the septa, extensively those blue color dots are not present. But in glomangioma condition, monomorphous, all dots are of similar size. Monomorphous, I will show you. See, they go. There are monomorphous. Here, look here. In the septa, how beautiful they are. See, they are monomorphous cells are present. Okay. So this is something very much important. Monomorphous round to polygonal cells. Okay. Now let's write one by one. Branching of the blood vessels is seen, no doubt. So in histology, what you can see is, yes, branching of the blood vessels. Here also there and there also there. Both the places. Cavernous also branching of the blood vessels are seen, and glomangioma also branching of the blood vessels is seen. Branching of blood vessels is seen. Not only that, what you can see, okay, monomorphous round cells are seen in the septa. Monomorphic round cells are seen in the septa. Okay, so that's the one important point I want you to know. Glomangioma, image based question they will give you. They will show you the nail bed and they will show you a small tumor and they will say it's a very painful tumor. What is this? Glomangioma. Okay, glomangioma. Image based question also. Now you know how to identify it. So these are the blood vessels. See here you can clearly see the RBC. So definitely this is a blood vessel. So in the septa, okay, in this wall, you can very clearly see monomorphous cells. Okay, monomorphous cells. After this, okay, we have completed the benign tumors. So the 3 benign tumors are completed. Okay, I have shown you 3 benign tumors. What are they? Capillary hemangiomas are the strawberry hemangioma, which will undergo regression by 7 years of age. Cavernous hemangioma, which will never undergo regression. Okay, associated with the von Hippel-Lindau syndrome. And glomangioma, nail bed tumor. 3 conditions completed. Now we have to discuss about Kaposi's sarcoma, sir. So regarding Kaposi's sarcoma, what are the important points which you need to know? Now my question to you, Kaposi's sarcoma is seen in which people? Guys, can you tell me Kaposi's sarcoma is seen in which people? Kaposi's sarcoma is seen in which people? Do you have any idea, guys? One more, excellent. It is seen in HIV or immunocompromised people. Immunocompromised patients. Okay, Kaposi's sarcomas. So these are the intermediate risk tumors which are seen in patients who are suffering with HIV or immunocompromised people. Now my question to you is, sir, what is the causative agent? Sir, it's a cancer. It's almost intermediate, like tumor. Okay, but what is the causative agent? Right. It is associated with a virus, sir. Actually, it is associated with a virus. A virus is going to cause this problem. What is the causative agent? Do you think HIV virus is causing this vessel problem? The tumor of these blood vessels? Kaposi's sarcoma? No. The causative agent is HHV8. Human herpes virus 8. Okay, human herpes virus 8, sir. So those people who are suffering with immunocompromised state, they will get this virus, HHV8 virus, and this HHV8 virus is going to go and attack the blood vessels, and that will cause Kaposi's sarcoma. Now, questions which were asked in the exam. What is the most common site? The most common site is lower limbs. Lower limbs, you can very clearly see these are the image based questions. They will give you, so what exactly? This is a classical image. Every time they will give you in your exam. This is the same image that will come in your exam, sir. Kaposi's sarcoma. Lower limbs are affected. Immunocompromised states. HIV patients. The causative agent is human herpes virus 8. Okay, and if you look at the biopsy, what you can appreciate? So this is the biopsy. What you can appreciate here? First of all, these are the blood vessels. No doubt, these are the blood vessels. These are the blood cells. These are all red color things are the blood cells. But if you look at these blood vessels, so the cells are like spindle shape. The cells, they are like spindle shaped cells. Okay, so the cancerous cells, they are like spindle shape. You can very clearly see the wavy spindle shape appearance, right? So on microscopy, what you will see? Microscopic examination on histology, there are spindle shaped neoplastic cells present. Okay, spindle shaped neoplastic cells are seen. Okay, along with the RBC and blood vessels, spindle shaped cancerous cells are going to be seen, sir. Okay, that's the important point about the Kaposi's sarcoma. Okay, it's not needed for you. Next, the last cancer which we are going to discuss is angiosarcoma. Angiosarcoma, what exactly it is? It's completely malignant, absolutely malignant, sir. It's a cancer. It's a cancer. Angio means blood vessel, sarcoma means cancer. So it's just for your understanding purpose. Some students like some students like me, they will just little deviate. They will just deviate, sir. We have completed benign tumors. Also, we have completed Kaposi sarcoma. Now we are going to start the angiosarcoma, malignant cancer. Okay. Now my questions to you: who will get this angiosarcoma? Very aggressive tumor, sir. Very aggressive. Very bad prognosis is there. Now, can you guys tell me? Angiosarcoma, who will get this? HIV patients, immunocompromised patients. Which patients are at risk of developing angiosarcoma? Come on. One more. Reen, Varun Kashyap, Dan, Rishiraj. Any idea? Who will get this? Those people who are exposed to certain chemicals. Arsenic, sir. Arsenic. Okay, arsenic poisoning. Polyvinyl chloride exposure. Okay, let me write first important points. So, angiosarcoma, it is a cancer. It's a neoplasm of which cells? Endothelial cells. It's a neoplasm of endothelial cells, so cancerous cells. Okay, it's a cancer of endothelial cells. Okay, what are the risk factors? Risk factors include arsenic. Okay, arsenic, polyvinyl chloride exposure, and thorotrashed. Okay, thorotrashed. What exactly is thorotrashed? It's a radio contrast agent used by the radiologist for getting better films. Okay, so it's a thorotrash. It's a radio contrast agent which is injected. Okay, so into the body. So thorotrashed exposure, thorotrashed can lead to angiosarcoma. Polyvinyl chlorides can lead to angiosarcoma, and arsenic poisoning can lead to angiosarcoma, sir. Okay, so how to identify this? MCQ. So these cells, these neoplastic cells, they are cancer of what? They are the cancer of endothelial cells, right? So these cells are positive. Okay, for which CD marker do you know? These cells are positive for CD31. CD31 positivity will be seen. Along with that, the cells are also positive for von Willebrand's factor. In immunohistochemistry, when you do the immunohistochemistry, even von Willebrand factor will be positive. Okay, the cells are positive for CD31 and von Willebrand factor. Why? Because they are present in endothelial cells. Von Willebrand factor is present in the Weibel Palade bodies of endothelial cells. Helps in platelet adhesion, aggregation, clotting. And CD31, it's a marker of endothelial cells. Even in the cell injury topic we have discussed. Okay, not cell injury, sorry, inflammation. The topic of inflammation we have discussed. The marker of endothelial cells is CD31. The marker of selectins is CD62. Okay, we have discussed about that. So, on microscopy, what you will see is microscopic examination. This cancer, if you do microscopic examination, there is no proper pattern. Atypical cells are seen. Atypical neoplastic cells. Okay, atypical neoplastic cells which are positive for CD31 and von Willebrand factor. With this, angiosarcoma is also completed, sir. Okay, and also we have discussed about the types of vasculitis. Okay, different types of vasculitis we have discussed. Also, we have seen about the important tumors which you need to know for your exams. That's the benign tumors as well as the intermediate risk tumors and the malignant tumors. And the malignant tumors are nothing but the cancers. We have seen the angiosarcoma. Okay, we have seen. Now in this class, okay, I'll be doing some vascular topics. Vascular topic is in the sense I'll be discussing about the arteriosclerosis. Okay, different types of arteriosclerosis, which includes arteriolosclerosis, Monkeyberg's medial calcific sclerosis as well as atherosclerosis. First, we will discuss about the arteriosclerosis topic. Later, we will be discussing about small topics like aneurysms as well as aortic dissection. Important MCQs we will discuss. Later on, we will discuss the most important clinical aspects in the cardiac pathology, sir. Today itself, we are going to start with the cardiac pathology, and in the cardiac pathology, we'll be starting with the acute. We'll be starting with the acute rheumatic fever. Okay, rheumatic fever. If possible, let's also try to do the infective endocarditis. Okay, I'm 100% sure, without any doubt, in your exams there will be a question coming from rheumatic fever. It doesn't matter whether it's FMG exam or NEET PG exam or INACT exam. One question will be there from rheumatic fever and one question will be there from infective endocarditis. No doubt in that. Okay, so we'll be doing patho as well as little integration also. These topics are going to come as clinical based questions. So we'll be doing little clinical integration also with the medicine. Okay, having said that, now let's begin our topic. Arteriosclerosis. Now you can ask me, sir, what the hell is this arteriosclerosis? Okay, what the hell is this arteriosclerosis? In the name itself, it's a arterio means the blood vessels, okay, the arteries, and the sclerosis. What exactly is the sclerosis, sir? Sclerosis means getting hardened. The arteries are getting hardened, sir. The blood vessels are getting hardened. Arteriosclerosis. Okay, literal translation is the blood vessels are getting hardened. Now you can ask me, how many types are there and why the blood vessels are getting hardened? There are three types of arteriosclerosis. Okay, there are three types. What exactly are they? They are arteriolosclerosis. Okay, arteriolosclerosis. Arteriolosclerosis means the arterioles are getting hardened. Okay, arteriolosclerosis. The second type is Monkeyberg medial calcific. Okay, calcific, medial calcific sclerosis. Okay, and the third type is atherosclerosis. See, there are three types. Okay, arteriolosclerosis, the arterioles are getting hardened, and Monkeyberg medial calcific sclerosis, the media, see in the name itself it's there, the media, the tunica media in the blood vessels. The blood vessels are made up of three layers: tunica intima, tunica media, and tunica adventitia. The tunica media is getting calcified. Because of that, the blood vessels are getting hardened. We will discuss about that. Okay, we will discuss about that. So anyway, arteriolosclerosis, Monkeyberg medial calcific sclerosis, and atherosclerosis. Okay, we will discuss about them one by one. Now, first let's begin with the arteriolosclerosis. Now, how many types of arteriolosclerosis are there? There are actually two types. Very important for your exam: hyaline arteriosclerosis and hyperplastic. Okay, so hyaline arteriosclerosis and hyperplastic arteriosclerosis. There are two types, right? Now, in which condition you will see hyaline arteriosclerosis? In which condition, sir? Such a type of hyaline arteriosclerosis, and the name itself is there. See, देखो, hyaline arteriolosclerosis means there is a deposition of a hyalinous pink color material. Okay, glossy pink color material is getting deposited in the blood vessel. That's actually causing the hardening of the blood vessels. Okay, so it's seen in which condition? I will show you the images also. It is seen in which condition? Hyaline arteriosclerosis is seen in benign hypertension. Okay, the patient is suffering with the benign hypertension. Hypertension is there, but it's not too much. Benign hypertension, 150, 160 mmHg range. Okay, so benign hypertension, hyaline arteriosclerosis. And then what is hyperplastic arteriosclerosis? What exactly is this hyperplasia? And is seen in which condition? Hyperplastic arteriosclerosis. It is seen in malignant hypertension. Okay, malignant hypertension means severe hypertension. Hypertension more than 200 mmHg. Okay, so more than 200 mmHg is the systolic blood pressure. So hyaline arteriosclerosis is seen in benign hypertension, hyperplastic arteriosclerosis is seen in malignant hypertension. Now, image-based questions are very much important for your exam. This is the blood vessel, sir. Okay, this is the blood vessel. See, this is the lumen of the blood vessel. You can very clearly see the RBCs also. Okay, this is the lumen of the blood vessel. Now, look at the wall. See, there is pink color. Okay, there is pink color, sir. See, this pink color hyalinous deposition. Okay, so because of the hypertension, the blood vessels are getting hardened. Okay, they are getting resistant to encounter this hypertension, means more blood pressure is there. Okay, as there is more blood pressure, the blood vessels are also getting hardened, sir. And some amount of blood vessel injury will happen. That blood vessel injury will lead to the injury to the endothelium, will lead to deposition of this plasma proteins into the vessel wall. The plasma proteins are now going to leak. The plasma proteins are getting leaked into the vessel wall. So this pink color deposition, pink color appearance, hyalinous appearance is because of the deposition of this plasma proteins in the vessel wall. Okay, so this type is called as hyaline arteriosclerosis. I have already mentioned here, dekho, hyaline arteriosclerosis is seen in benign hypertension. Now, if you are suffering with malignant hypertension, dekho, if you are suffering with malignant hypertension, the systolic blood pressure greater than 200 mmHg, look at the blood vessel, how it is looking like. So the smooth muscles, in order to encounter such high stress, there is more blood pressure, more pressure is there. There is more and more pressure, the blood vessels can even rupture. So to prevent this, in order to encounter such a stress, the smooth muscles in this blood vessel, now they are dividing, and what they are forming? They are forming like, onion skin kind of appearance. Okay, onion ring, onion skin kind of appearance. Okay, so that's why this is called, see, many layers are there, hyperplastic. Okay, like an onion skin. So this is called as hyperplastic arteriosclerosis, where you will be seeing the onion skinning. Okay, onion skinning. And here there will be fibrinoid necrosis also. Okay, there will be fibrinoid necrosis because the vessels are dying and pink color deposition is also happening here. Fibrinous depositions are happening. So it's an example of malignant hypertension can lead to fibrinoid necrosis. True. Okay, that's the one important point I want you to know. So anyway, just let's come back. We are discussing about what? We are discussing about the topic of arteriosclerosis. How many types? 3 types: arteriosclerosis, Wonky-Burke's medial calcific sclerosis, and atherosclerosis. Arteriosclerosis is divided into 2 types: hyaline as well as hyperplastic. Hyaline is seen in benign hypertension. Hyperplastic with onion skinning of the blood vessels is seen in malignant hypertension, where the systolic blood pressure is more than 200 mmHg. Done, sir. Done. Next, the second type is Wonky-Burke's. Okay, Wonky-Burke's medial calcific sclerosis. Look here. So this is the blood vessel. You know it. This is the lumen. Okay, this is the lumen. Okay. Now, this layer will be tunica intima. The innermost layer is the tunica intima. What is this layer, sir? The tunica media. Okay. So this layer, which let me highlight. So this layer is a tunica media. Now, in that tunica media, are you able to appreciate this pink color deposition? So what is that? It's nothing but the calcium deposition, sir. The calcium is coming and getting deposited in the tunica media of the blood vessels. So calcification is happening. Why? So it is going to be seen in older individuals with aging. The calcium will start to come and deposit in within the blood vessels. Here also you can clearly see, sir, all this is the calcium deposition. Where the calcium is getting deposited. So the calcium, it is getting deposited within the media. So that's why the name. Wonky-Burke medial calcific sclerosis. The sclerosis is because of the calcification. Which layer is getting involved? The tunica media is getting involved. If tunica media is involved, will there be any problem for the normal lumen? Will there be any problem for the normal lumen? The normal lumen diameter is not going to be compromised. The normal lumen is going to stay normal. Okay, the lumen is going to be it's not going to be occluded. So it's not a severe condition. It's not a severe condition. So the important points which I want you to know for your exam are, so let me write. In Wonky-Burke medial calcific sclerosis, there is a dystrophic. There is a dystrophic calcification. Even in this X-ray, you can very clearly see in X-ray, the bones are going to appear white in color. See, this is the blood vessel, sir. This is actually a blood vessel. See, in the blood vessel, okay, the calcium is getting deposited. The calcium, sir, Okay, it's not a contrast, it's the calcium which is getting deposited over there. So that's why even in the blood vessel you are seeing this white color. The blood vessel is coming white color because the blood vessel is getting ossified, getting calcified. The tunica media is getting calcified. So it's an example of dystrophic calcification. In the first general pathology, in general pathology topic, in the cell injury topic, I have discussed the difference between dystrophic calcification and metastatic calcification. Okay, dystrophic calcification and metastatic calcification. I'm not going to again in details about the what exactly is dystrophic calcification, but here this Monkeyberg medial calcific sclerosis is an example of dystrophic calcification. Sir, seen in whom? Seen in old age people. Is it significant? This is not significant. It's a not significant, so it's not a significant condition, not a problematic thing. The way because the tunica intima is not involved, the lumen is not involved, so there won't be any occlusion. There won't be any occlusion. There won't be any thrombus formations. Okay, simple. So this is done. Now after this, now I am showing you an image. Okay, I am showing an image. You should tell me what exactly is happening over here. Now it's your turn. Now it's your turn. The image based question. Now what is happening? You can very clearly see, sir, the lumen, the patency of the blood vessel is getting narrowed. The lumen is getting narrowed. Here also, see, the lumen is getting narrowed. Small lumen, sir. Okay, let me put it this way. Okay, small. Why? Are we able to appreciate this lipid kind of material getting deposited over there? That's actually lipid, sir. That's a lipid core. Okay, see the lipid. See, this is the lipid deposition. Lipid is getting accumulated over there. So because of this lipid, what is happening to the patency of the blood vessel? The blood vessel is getting narrowed. And do you know what happens? Sir, this atherosclerosis, this is actually atherosclerosis, sir. The blood vessels are undergoing atherosclerosis. Now this atherosclerosis, these plaques, they will rupture. The atherosclerotic plaques, they will rupture. Whenever they rupture, platelets will start to come and accumulate in that area. Platelets will come and platelet adhesion, platelet aggregation will start to happen in that area. So forming what? See, there is a thrombus formation. Okay, thrombosis will occur, sir. So what I am trying to put into your mind, so whenever you are talking about atherosclerosis, the risk factor, the problem with atherosclerosis is there will be one day that this atherosclerotic plaque will rupture, and whenever it ruptures, it will develop. Now thrombosis will start to develop. Now the thrombus will grow and completely occludes the blood vessel. It will completely start to occlude the blood vessel, sir, leading to coronary heart diseases, unstable angina and myocardial infarction can occur. Okay, so the image, let's come from the basics. The image which you are seeing here, these blood vessels which are getting narrowed, it's all because of a problem called as atherosclerosis. Okay. Atherosclerosis. Now question to you, why? Why atherosclerosis? Any idea, guys? Buddies, any idea why exactly the atherosclerosis? Can you guys tell me any, can you guys recall any risk factors for the atherosclerosis? I will go one by one. Let's keep it as simple as possible. Lifelong, remember this. Okay, let's keep it as simple as possible. So, first, atherosclerosis, it is response. Why happens? Why atherosclerosis, sir? Why atherosclerosis? I will first listen this. It's a response to endothelial injury. It's a response to endothelial injury. Injury one time, two times? No. For example, if there is an endothelial injury which is going to happen in my blood vessel, do you think atherosclerosis will happen? No. Not one time, sir. Chronic injury. Chronic injury that is happening to the endothelial cells. Continuously there is injury. Okay, not one time, two time, continuously, chronic thing. So let me tell you why there is endothelial injury, sir. Why endothelial injury is happening? First of all, you need to know the risk factors. Risk factors for the atherosclerosis. Why a person will develop atherosclerosis? Risk factors are, let's write, smoking. Smoking, the person is taking the chemicals into his body. He is taking the carcinogens. He is taking a lot of chemicals into the body. Whenever I smoke, I am taking all these chemicals into my body. These chemicals, where they will go? They will go into the blood. So these chemicals now will start to damage the endothelium. Simple as that. These are the chemicals. If I start to do the smoking, I am just inhaling the gases, the toxic gases from my lungs. These gases or these chemicals will start to go into the blood vessels. So these chemicals will start to damage the endothelial cells. Simple. Okay. So smoking, alcohol. Okay, alcoholism, smoking, alcoholism. Next, the persons who are having hyperlipidemias. Okay, or the persons who are having infections, certain types of infections. Now this is the question, guys. Can you tell me which infections are associated with atherosclerosis? NEET PG question and INACD level questions. Which infections are associated with development of atherosclerosis? There are 3 infections which you need to know for your exam. Herpes infection. Next, chlamydia, herpes, chlamydia and cytomegalovirus infections. Next, those persons who are having obesity, diabetes mellitus and hypertension. So all these are the risk factors, sir. Smoking, alcoholism, hyperlipidemias, infections, having obesity, diabetes, hypertension. See, in all these cases, whatever I have shown you here, in all these cases, at the end of the day, there will be continuous endothelial injury. Endothelial cells are getting injured continuously. Okay. Now, not only this, there are certain other important risk factors also, like male sex, type A personality, like type A personality who are always anxious, who are always alert, like worried about everything. Okay, type A people who are like goal oriented, always they will be continuously working. Stress people, always they are taking the stress. Okay, so type A personality and old age. Next, homocystinemia. Okay, homocystinemia, it's a disease, homocystinemia. See, in all these conditions, what I have explained to you, these are all the risk factors. All these risk factors at the end of the day, what they will do, sir? They will do endothelial injury. Okay, they will cause endothelial injury, sir. Now, you should know, sir, which of the following are the modifiable risk factors and which of the following are the non-modifiable risk factors. For example, which risk factors you can modify, which are under your control. Sir, smoking, you can control it. Alcoholism, modifiable. Hyperlipidemias, you can control your lipid levels. Infections, you can get protection, you can take the protection from getting these diseases. Herpes, sexually transmitted disease, like you can get the protection, you can, like it's a modifiable thing, right? And obesity, okay, obesity, you can control your BMI. Diabetes can be controlled, hypertension can be controlled. Okay, these are all the things which are under your control, sir. You can control them. Okay, risk factors. But male sex, once you are a male for lifelong. Okay, you cannot change it. You cannot change it at any point of time. So male sex, the personality, usually the personalities can also be not changed. Okay, so let me put it in a different color. So male sex, type A personality, age. The age is not under your control, and homocystinemia, this disease, okay, it's a disease which is not under your control. Once you will get it, homocystinemia, like it's a autosomal recessive disorder. By birth itself you will get it. It's not under your control. So these are the modifiable risk factors which I have shown you in the yellow color, and non-modifiable risk factors which I have shown in the pink color. At the end of the day, there will be endothelial injury. Now what exactly is atherosclerosis? Already I have explained you. It's a response to endothelial injury. Whenever the endothelium it is getting injured, now there will be a response by the body. So what is that response, sir? Now that we have to study. So let's write first. What is happening? There is endothelial injury. Whenever there is endothelial injury, what happens? Now, endothelium, it's forming which layer, sir? Which layer? Intima. So, intima is damaged. Intima is damaged. Simple, right? The intima, endothelium forms the intima. So, the intima is getting damaged, sir. When the intima is getting damaged, guys, look here. Okay, now this is the intima, right? Intima. See, all these are the risk factors. Now, what these risk factors are doing, sir? These risk factors, they are causing damage to the intima, endothelial layer. Now, when the endothelial layer, it is damaged, now look here. Sir, these cells, there are certain cells. See, the platelets, these green color cells are the platelets, as well as this pink color cell, where the damaged endothelium, look, carefully look here, where the damaged endothelium, they will start to enter into the tunica media. Now they will start to enter into the tunica media. Okay, first they will come into the intima, later they will go into the tunica media. So let's write one by one. Intima is damaged. After the intima is damaged, macrophages. Come on guys, macrophages. And platelets. Where they will come, they will enter into intima. Now later what happens? So now guests came into the home. Now do you think the guests are the relatives? Are they going to sit calm? No, the relatives are not going to sit calm, sir. Always they will do some nonsense, right? So even this macrophages and platelets, once they enter into the blood vessel wall, now they will start to release the growth factors. So they will release growth factors. They will start to release the growth factors. Now look here. Now these macrophages and platelets, now they are entering into the wall of the blood vessel. Now see these, what they are releasing, are you able to appreciate? See, the chemicals are being released, the small chemicals are being released because of these chemicals. Okay, these are the growth factors, sir. These are the growth factors. Now because of these chemicals, are you able to appreciate the smooth muscles? Dekho, these are the smooth muscles, this is the tunica media, right? The muscles, the smooth muscle cells, now they will start to enter into the intima. Now they will start to enter into the intima, sir. Okay, now the smooth muscles are entering into the intimal layer. Now let's write that. Release of the growth factors, smooth muscles, okay, migrate into intima. Okay, now do you think it's a normal intima now? No, this is not normal intima. Why? Because now smooth muscles entered into the intima. Now this is called as neo-intima. Okay, now there is a neo-intimal formation. Neo-intima is because of the migration of the smooth muscle cells into the intima cell. Okay, now these smooth muscle cells, what they will do? Now they have entered into the intima cell. Now what these macrophages and what these smooth muscles will do? See, endothelium is damaged, right? The endothelium is damaged. Now when endothelium is damaged, now the LDL cholesterol, the LDL molecules will also start to come and deposit here. Now LDL is also getting leaked. The LDL is also getting leaked into the vessel wall. Now, dekho, now what is happening? Sir, these macrophages, these are the macrophages, sir. And these are the smooth muscles. Okay, the smooth muscles. Now the macrophages and smooth muscles, they will start to engulf. They will start to take this LDL cholesterol. All this LDL cholesterol, whatever is getting deposited in the vessel wall, now it will be taken into the cells. The macrophages and the smooth muscle cells, they will engulf this LDL cholesterol. So next, right? What happens is the smooth muscles and the macrophages, engulf what? Engulf the LDL. Okay, they will engulf the oxidized LDL, sir. Okay, now where exactly is this LDL present? Now this LDL is present inside the macrophages and inside the smooth muscles. Now these cells, now these macrophages which are loaded, with the LDL cholesterol, now such cells are called as, okay, these cells are called as foam cells. So the smooth muscles and the macrophages which are loaded with the LDL cholesterol, oxidized LDL, after taking the LDL they will do oxidation. So they are called as foam cells. Okay, so what are foam cells? Foam cells are the lipid laden macrophages. Okay, so LDL which is present in the macrophages, these macrophages are called as the foam cells. Done, sir. Now what they will start to do is, with the time the foam cells will start to accumulate, the collection of foam cells. Collection of foam cells okay, collection of the foam cells forms the fatty streak. Now these foam cells, they will start to accumulate. Now the foam cells, many number of macrophages and many number of the smooth muscle cells, now they are starting to accumulate. Okay, they are totally filled with the cholesterol, sir. Now the collection of the foam cells forms the fatty streak. Okay, now this fatty streak is important, sir. It's the first visible or first morphological change that is seen. The first morphologically visible thing in atherosclerosis is fatty streak. So now tell me what happens. Very simple. There are certain risk factors important for your exam. What are the risk factors? Modifiable risk factors and non-modifiable risk factors. Smoking, alcoholism, diabetes, obesity, hypertension, and certain infections like herpes, chlamydia, and cytomegalovirus, and non-modifiable risk factors like male personality, male sex, type A personality, and old age, and certain conditions like homocystinemia. So this homocysteine, now it will also damage the endothelial cells. But at the end of the day, the endothelial cells are getting damaged. Now there should be a response. The body is responding. How the body is responding? Whenever there is an endothelial injury or intimal injury, now the macrophages and the platelets, they will start to get into the vessel wall. Now they are starting to enter into the tunica intima. Now after entering into the intima, now they start to release the growth factors. Now because of these growth factors, the smooth muscles which are present in the tunica media, now they will start to enter into the tunica intima, which will form neointimal formation. Now once neointima is formed, okay, now what these macrophages and what these smooth muscle cells will do? Now they start to engulf, they start to take the LDL cholesterol which is leaked into the vessel wall. Okay, because of the endothelial injury, even these cholesterol molecules, okay, not just the cholesterol, not just the LDL cholesterol, even platelets, RBC, WBC, many things will start to come into the blood vessel, but the macrophages and the smooth muscles, they will start to engulf the LDL cholesterol and they become foam cells, they become the foam cells. Now I am having one foam cell. Now many number of foam cells, they will start to accumulate and forms a fatty streak. Now see, the cholesterol core, the lipid cholesterol core is going to form, sir, because of this accumulation of many number of foam cells. So within the vessel wall, these foam cells are accumulating and forms at the end of the day atherosclerosis, done. Okay, so what are the important points which you need to know in your exam? Earliest visible lesion. The questions that can come in your exam is earliest visible lesion. The earliest visible lesion is fatty streak. What exactly is fatty streak? It's a collection of the foam cells. Okay. Now you can ask me, sir, atherosclerosis, where exactly it's going to occur? What's the most common site? Most common site of atherosclerosis. Any idea, guys? What is the most common site of atherosclerosis? There is a mnemonic. Okay, ACP. ACP, sir. The most common site is ACP. Means abdominal aorta. Okay, abdominal aorta. C for coronary arteries. Most of the students will think coronary arteries are the most common site of atherosclerosis. No, it's the abdominal aorta. Okay, I will show you the image also. So coronary arteries followed by popliteal artery. Okay, so abdominal aorta, coronary arteries, and popliteal arteries. This is the order, sir. This is the order of atherosclerosis. So what is the most common blood vessel that is affected? Abdominal aorta is most commonly affected in the atherosclerosis. Next, what is the least common site of atherosclerosis? Okay, atherosclerosis can occur in any blood vessel. What is the least common site? Most common site is abdominal aorta. Okay, what is the least common site? The least common site is circle of Willis in the brain. Okay, circle of Willis in the brain cell. Next, complications. So if there is atherosclerosis, okay, so what are the complications? I have explained you atherosclerosis, this is atherosclerotic plaque. It will rupture one day, it will grow and one day it will rupture, sir. Totally the intima totally is going to be ruptured. Okay, now when it is ruptured, what happens? Platelets will start to come and accumulate over there and forms a thrombosis. Okay, so rupture, complication is rupture. Today or tomorrow it will rupture. Whenever it is ruptured, that will form thrombus. Will form the thrombus. the thrombus can lead to first angina and myocardial infarction. Okay, myocardial infarction, coronary artery disease, sir. Coronary artery disease or myocardial infarction. Now, that blood vessel which is having atherosclerosis, may develop aneurysms. Okay, aneurysms, and that blood vessel may develop dissection. Okay, dissection, sir. Okay, the blood vessel wall, the wall of the blood vessel might tear up into two parts. Okay, two parts. There is a possibility. So, what are the complications? The complications are rupture, aneurysmal formation, and dissection. These are the three complications which you need to know for your exam. Now, look here, guys. What exactly is this? So, here this is the descending aorta, right? You know it. This is a descending aorta. Sorry, let me put it this way. I shouldn't say descending aorta. So, this is abdominal aorta. Okay. First ascending aorta, arch of aorta, descending aorta in the thorax. Now once it is entering into the abdomen, it is abdominal aorta. So now this is abdominal aorta. Now at the L1 segment, you know it, the renal arteries are arising. Okay, these are the renal arteries going for the kidneys. Now down to the renal arteries. Okay, down to the renal arteries. So are you able to appreciate here what happened? So this part of abdominal aorta have developed the atherosclerosis, and here you can also see the aneurysm, the dilation. The blood vessel is that abdominal aorta is totally dilated. Why? Because of the atherosclerosis. So this is the most common site of atherosclerosis. You know, abdominal aorta is the most common site of atherosclerosis, but where? See, this is also abdominal aorta. Where exactly in the abdominal aorta? Below the renal arteries. Below the renal arteries. See, guys, can you tell me what is this area? The abdominal aorta is dividing. The abdominal aorta is bifurcating into iliac arteries. Okay, common iliac arteries. So this is the site, this is the most common site of atherosclerosis. Okay, here also we can very clearly see. So here there is bifurcation. This is the place where bifurcation is happening. Okay, into the common iliac arteries. Now, this is the abdominal aorta. Okay, you can go through this explanation. If you want to go, you can take a screenshot and you can go through this explanation. The same thing. Okay, the most common site, let me write here. Most common site in abdominal aorta. It is below the renal arteries and above the iliac, below the renal arteries, and above iliac, the common iliac arteries. Okay, before the bifurcation of the common iliac arteries. So with this, the topic of atherosclerosis is completed. Okay, all the important points, whatever you need to know for your exam, it's completed, sir. Image based questions. Okay, usually atherosclerosis is something associated with. Here also you can see there is a dilation of the blood vessel because of the atherosclerosis. Clearly look here, there is atherosclerosis in the blood vessel, sir. Okay, there is atherosclerosis there. Okay, now after this, let's talk about a small topic, a simple topic, which is called as aneurysms. Just not the dilation. See, even for example, if I take nitroglycerin, okay, if I take nitroglycerin, that will also cause dilation, sir. Okay, that will also cause a dilation. It's a irreversible dilation. Okay, you should say one more. It's a irreversible dilation of the blood vessels. Okay, of course you said abnormal. Yeah, you should say, sir, there is irreversible or permanent dilation of the blood vessels. Irreversible or permanent dilation of blood vessels. Permanent dilation of the blood vessels. Okay, dilation of blood vessels or even heart. Okay, now questions that will come in your exams are, how many types of aneurysms are there? How many types? There are 3 types of aneurysms. Simple. There are 3 types. What are they? What are the 3 types of aneurysms, sir? The 3 types of aneurysms are true aneurysms. Second types are pseudo aneurysms, and third type are mycotic aneurysms. Okay, there are 3 types of aneurysms. Just give me 1 minute. Okay, so there are 3 types of aneurysms which I want you to know: true aneurysms, Pseudoaneurysms and mycotic aneurysms, 3 types of aneurysms. Now you can ask me what exactly is a true aneurysm, sir? Now here this is a normal blood vessel. You know there are 3 layers in the normal blood vessel, sir. Tunica intima, tunica media, tunica adventitia, 3 layers. Now here you can clearly see, so the blood vessel is dilated. Now in this dilation process, see all the 3 layers are involved. Okay, all the 3 layers are involved. As all 3 layers are involved, it is called as a true aneurysm. It's called as a true aneurysm. Okay, here also dekho, sir, in this dilation process, all the 3 vessel layers are involved. If all the 3 vessel layers are involved, then it is called as a true aneurysm. Okay, true aneurysm. Okay, it can be on one side or it can be on both sides. That's a different thing. That's a different thing. But what is a true aneurysm? Right? All 3 layers are involved. Okay, all 3 layers are involved, sir. Then what exactly is a pseudoaneurysm? Then in pseudoaneurysm or false aneurysm, okay, pseudoaneurysm or false aneurysm, they go here. See, there is a damage. Okay, they go here. There is a damage to the blood vessel. There is some trauma. There is damage to the blood vessel. Now, see, the blood is coming out like this, and it's forming a hematoma, sir. Now it is forming a hematoma. Okay, so here is the extravascular connective tissue. That's the extravascular connective tissue. Now the blood is forming a hematoma. Now if you look it from outside, if you are looking it from outside, it's just looking like the blood vessel is dilated. It's not just that blood vessel is dilated, sir. It's the damage which happened to the blood vessels leading to the hematoma formation. There is a hematoma. A clot is there within the blood vessel. Okay, so externally it looks like a dilation. So these are false aneurysms. These are not the aneurysms. These are the pseudoaneurysms. Okay, so pseudoaneurysms are due to hematomas. They are because of the hematomas. They are seen in the hematomas. Now last but important, mycotic aneurysms. So can you guys tell me what exactly are these mycotic aneurysms? Mycotic aneurysms, what exactly are they? Okay, see, the name is saying mycotic. Mycotic here, it doesn't mean because of some fungus. Mycotic, you know, mycology means study of fungus. But here it's not because of the fungus, sir. It's because of some bacteria. Which bacteria? Staph aureus. Okay, so when you are having infection to the blood vessels, that even causes the aneurysms. So dilation of your blood vessels seen in infections are called as mycotic aneurysms. Mycotic aneurysms are most commonly because of which organism? Most commonly because of Staph aureus. And what is the most common blood vessel that is involved? The most common blood vessel that is associated with the mycotic aneurysms are femoral artery. Okay, associated is a femoral artery, sir, important. Okay, femoral artery. Now, apart from this, true aneurysm, pseudoaneurysm and mycotic aneurysm, I want you to know a little high yielding thing. There is one more aneurysm which is called as lytic aneurysm. Okay, lytic aneurysm, sir. Okay, bacteria, not the fungus, bacteria. Okay, so lytic aneurysm. So, lytic aneurysms are seen in which conditions? So, lytic aneurysms are associated, they are seen in a condition called as syphilis. Okay, tertiary syphilis. Okay, now this is the image based question, very important image based question. So you can clearly see here the aortic root, the aorta, the starting part of the aortic root is getting dilated. Okay, the aortic root is dilated, sir. Even the entire aorta is affected. If you look at the aorta, sir, now the aorta, it's looking like a tree bark, the bark of the tree, you know the bark of the tree, right? How it looks. So these lytic aneurysms are seen in which condition? Tertiary syphilis. Okay, so how these syphilitic aneurysms, how these syphilitic aneurysms are going to appear? See, there will be tree barking appearance. Tree barking appearance. There will be tree barking appearance. Now, one more important point I want you to know is, so because of this aortic root dilation, you just think logically and tell me, so the aortic root, the aorta, it's getting dilated, aneurysm, aortic aneurysm, the aortic root is getting dilated. When the aortic root, when it is getting dilated, what happened to the aortic valves? So near the aortic root only, no aortic valves will be there, the leaflets, the aortic valve leaflets. Now these aortic valve leaflets are also going to go away from each other, moving away from each other. So what will happen? There will be aortic regurgitation. Blood will enter into the aorta and again the blood will come down. The blood will come down, fall back into the left ventricle. So in this condition, the patient is going to have, note, the patient is going to have in this aortic root dilation, the aneurysms which are seen in tertiary syphilis, there will be aortic regurgitation. Okay, aortic regurgitation. Okay, so blood will fall back again into the left ventricle, sir. So that's the one thing which I want you to know. Syphilitic aneurysms are seen in tertiary syphilis. Syphilis is because of which organism? Treponema pallidum, the spirochete. Okay, so whenever you are having infection, okay, whenever you have specifically infection with this organism, okay, what happens is, I don't want to go in detail, there will be something called as obliterative end arteritis. Obliterative end arteritis that will cause aortic root dilation and tree barking appearance. Enough. Okay, so after this, what else you should know? The next topic which we have to discuss for the exam is this one. Yes, can you tell me what exactly is happening here? They go. Now this is aorta, you know it, right? This is the aorta, sir. Okay, aorta. Now there is a damage to the vessel wall. Now the blood is entering into the vessel wall. So the jet of blood is going to enter into the vessel wall, and the vessel wall is going to split into two parts. There is a splitting. Okay, there is splitting. So here also you can very clearly see there is damage. The blood is entering. Now the blood is flowing where? The blood is flowing through the vessel wall, and this blood is again coming back into the lumen. With again there is one more damage here. Again the blood is again coming back. Okay, coming back, sir. So this is what? This is aortic dissection. So here this is the real image, the gross image. You can see the blood is in the wall. Okay, done. Now what you need to know for your exam? Aortic dissection. Now, right, jet of blood. What is happening? Jet of blood flow through the vessel wall. Okay, flowing through the tunica. Where? Flowing through the tunica media. Vessel wall means in the tunica media. Tunica media. Now, question, sir. What are the most common causes? Sir? Why aortic dissection? Okay, what are the causes of aortic dissection? The most common cause of aortic dissection MCQ in your exam is hypertension. If there is hypertension, the vessel wall will be damaged, and this blood will start to enter into the tunica media. So that's the hypertension, sir. And other causes includes, we have seen, even in the topics of genetics, we have discussed about Marfan syndrome. The autosomal dominant disorder. The most common cause of death in Marfan syndrome is aortic dissection. In Marfan syndrome, connective tissue disorder, the fibrillin, okay, the fibrillin protein is the fibrillin protein is defective. Okay, the fibrillin protein is going to be defective. Connective tissue disorder, there is weak connective tissue. So the connective tissue and the blood vessels are also very weak, so they will be easily damaged. The blood will start to enter into the vessel wall. So Marfan syndrome, that's the one cause. In Marfan syndrome, what happens? There is cystic, right? This is important. Cystic medial necrosis. There is something called as a cystic medial necrosis of the vessel wall. The vessel walls are very weak. The connective tissue in the vessel wall is weak now. So there will be cystic medial necrosis that will lead to aortic dissection. Now, if you are having aortic dissection, for example, see, if I am the person right now, if I am having aortic dissection, what will be the classical clinical feature? So the clinical features are going to be sharp pain. Where? In between the scapula. Okay, there will be very sharp pain, very sharp, severe pain in the mid-scapular region. Okay, there is a sharp pain in the mid-scapular region, sir. That's the one important point I want you to know. Okay, so you can very clearly see here. So this is the true lumen. See, there is a true lumen, and here is a false lumen, sir. The blood vessel wall, it is getting split into two parts. There is a false lumen and it is a true lumen. Now you can, just by looking at this, you can understand what's the problem with aortic dissection. Because of this aortic dissection, the normal lumen patency, the patency of the lumen is going to be narrowed. Okay, so look here also. See, this is the false lumen now. See the blood is there here in the false lumen. So this here also, see, the blood is going through the false lumen. So that the original lumen, the true lumen is going to be totally obliterated. Okay, so that will actually kill, it's a medical emergency, sir, it will actually kill the patient. Okay, so done. So aortic dissection topic is also completed. Now after this, let's start with the cardiac pathology. Okay, in the cardiac pathology, let me tell you what are the important topics that we are going to discuss. So in the cardiac pathology, first we will start with the rheumatic fever. Okay, very important for your exam. Next you should know infective endocarditis. After that you should know about the different types of vegetations. Next, we have to discuss about the coronary artery diseases, like what is stable angina, unstable angina, and next we have to discuss about myocardial infarction. After myocardial infarction, what are the like changes which you will see in the labs? What are the changes you will see? What are the ECG changes? Okay, what is ST elevated MI? What is non-ST elevated MI, STEMI and non-STEMI? We have to discuss. After that, we also have to go through the cardiomyopathies. Okay, cardiomyopathies, hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy. Also, we have to discuss about cardiac tamponade. Okay, what is cardiac tamponade and constrictive pericarditis. So these are the important topics that we are going to discuss in the cardiac pathology. Now, having said that, let's, without any further late, now immediately start the topic of rheumatic fever. Okay, rheumatic fever. Let's begin with the rheumatic fever. See, now many students will have a confusion. So what is rheumatic fever and rheumatic heart disease? Are they one and the same? First itself I am telling you, see, first the person is going to get the rheumatic fever. In this rheumatic fever, if there is heart involvement, if the heart is involved, then it is called as rheumatic heart disease. So first rheumatic fever plus heart involvement is rheumatic heart disease. Okay, you will understand it one by one. So now let's begin with the rheumatic fever. Next, and rheumatic heart disease. First we will discuss about rheumatic fever and rheumatic heart disease. Now my question to you, who will get the rheumatic fever, you and me? Will we get the rheumatic fever? Usually no, sir. Usually the possibility is going to be very less. Usually rheumatic fever, very much important for FMG exam, it is seen in between these years, 10 to 15 years. Okay, in some books mention 5 to 15 years. Rheumatic fever is something seen before 15 years, sir. Before 15 years, 5 to 15 years or 10 to 15 years, both are true. Depends on the book. Both are true, sir. Most commonly, it is going to be seen in female children. Okay, female children. It's an example of type 2 hypersensitivity reaction. Okay, it's an example of what? It's an example of type 2 hypersensitivity reaction. We will go one by one in detail. We will discuss. First, general points I am telling you. Acute rheumatic fever is seen in females. True. Acute rheumatic fever. What the hell is this, sir? What the hell is this? See, this is an autoimmune disease. Okay, autoimmune disease. You know, all autoimmune diseases are coming under type 2 hypersensitivity reactions. Autoimmune diseases are most commonly seen in females. Okay, which females? Children, sir. Children are going to be affected. Okay. Now, why there is this autoimmunity? Let me tell you in a simple way. First, let's look at here. Now, imagine there is this one child. So this is the gold child, happy child. Okay, such a small child of, for example, 10 years. Okay, 10 years, female, sir. Now this 10-year female, now she got an infection in her throat. Okay, now she got an infection in her throat, sir. Throat infection. That is what? Pharyngitis. Okay, pharyngitis. Now, this pharyngitis is because of which organism? It's because of gas, group A, streptococcus. There is an organism called as group A beta hemolytic streptococcus. Okay, because of this group A beta hemolytic streptococci, now this female is having pharyngitis because of this group A beta hemolytic streptococci. Now she is having pharyngitis, throat pain. Now tell me, her immune system is going to be activated or not? Yes, her immune system is activated, sir. Now this is the bacteria, right? Now this is the bacteria. Okay, now the bad guys, sir. This is the bacteria. Now look here, this bacteria in its cell wall, okay, it's having a protein, sir. It's having a protein. This protein is like an antigen. Now it's acting like an antigen. Of course, bacterial things are antigens. Bacterial cell membrane components are the antigens. Okay. Now this protein name is called as M protein. Okay, M proteins. Now, see, the point here which I want you to know is, sir, this girl's immune system is getting activated. Now, the antibodies are getting produced. The antibodies, now they will start to go and attack this bacteria. Okay, the M protein. But what happens is here, the antibodies which are produced against the bacteria, now these antibodies will start to attack. Okay, this is not why, this is the antibody. Okay, antibodies will start to attack own tissues. Sir. So why, you can ask me why? Why? Because see, this M protein, which whatever is there, the M protein which is present in the bacteria, this M protein, the M protein resembles N-acetyl glucosamine. Okay, the N-acetyl glucosamine, sir. In our body, in our every damn cell, okay, in our every damn cell, there is this N-acetyl glucosamine present. N-acetyl glucosamine is present in our own body. Now, this N-acetyl glucosamine and the M protein, they are having the similar structure. They are having the same structure. So, these antibodies are confused. Our immune system is confused. So, the antibodies which are produced against the M protein, yes, of course, they will attack the bacteria, no doubt. But they will also start to attack my own heart because N-acetyl glucosamine is present in my heart. These antibodies will start to attack my brain because N-acetyl glucosamine is present in my brain. It will start to attack the skin, start to attack the joints. Okay, now this antibodies will go and start to deposit in the joints, leading to the joint pain, heart involvement, skin involvement, okay, and brain involvement. Okay, so this is the concept, sir. So here the main problem here is molecular mimicry. Okay, there is molecular mimicry. So who is doing this molecular mimicry? M protein. The M protein resembles N-acetyl glucosamine. Okay, that. My question to you. See, imagine you are a child. Imagine you are a child of 15 years or 10 years. Now you got group A beta hemolytic streptococcal pharyngitis. You got the pharyngitis. So, are you going to develop this rheumatic fever? Are you going to develop this rheumatic fever? No, not everyone. Just 3% of the population. Just 3% of the population. 3% of the individuals, unlucky fellows. 3% of the fellows who are living in poor, unhygienic conditions in underdeveloped countries. Okay, those fellows will develop rheumatic fever, acute rheumatic fever. Okay, acute rheumatic fever. Okay, if 100 individuals, they are getting the group A beta hemolytic streptococcal pharyngitis, out of 100, 3 people will develop rheumatic fever. Okay, so now let's see one by one important points. Dekho, highlight. So it's an autoimmune inflammatory disease. Autoimmune disease, I have explained you. Caused by what? Caused by group A, that is beta B, that is group A beta hemolytic streptococci. Which strains? There are different strains. Okay, strain number 1, 3, 5, 6, 18. 1, 3, 5, 6, 18. These are the important strains of group A beta hemolytic streptococci which can lead to rheumatic fever. See, sir, it occurs only secondary to sore throat or pharyngitis. Okay, streptococcal sore throat or streptococcal pharyngitis. See, even you can get the streptococcal skin infection, sir, which is called as impetigo. Streptococcal infection to the skin. So, this streptococcal skin infection or this impetigo will not cause rheumatic fever. It is a streptococcal pharyngitis can lead to rheumatic fever. Okay, that's important MCQ. I have explained you only 3% of the cases will develop the rheumatic fever or rheumatic heart disease. I should say rheumatic fever, sir, mainly rheumatic fever. Okay, rheumatic fever. Okay, only 3% of the cases with this pharyngitis can develop the rheumatic fever first. Now, what is the pathogenesis? Explained you the pathogenesis is molecular mimicry or the cross reactivity. Antibodies are mistakenly attacking the N-acetyl glucosamine. So, the target here is the N-acetyl glucosamine. Okay, so M protein resembles which antigen in the body? N-acetyl glucosamine. Okay, so done. Now, these antibodies will also start to attack the heart, leading to carditis, heart involvement. If the heart is involved, I have explained, if the heart is involved, then it is called as rheumatic heart disease. So, what is that cardiac involvement? See, the one question, now itself I am telling you repeatedly in your exam, this is the question that will come. In just general FMG exam, in FMG exams, they will ask you, what is the most common valve affected in rheumatic heart disease? Mitral valve, sir. This is the question which was asked, I think, almost 5-6 times. Most common valve involved in rheumatic fever is mitral valve. Which valve is not affected? Sir, which valve is not affected? Pulmonic valve. Okay, pulmonic valve is almost not affected, sir. Okay, least affected. Okay, so done. Having said that, shall we begin the topic? Now, look here. Okay, let me put it this way. Now, imagine I am the one who is having rheumatic fever first. Okay, let me say something like this. Imagine I am the one who is having rheumatic fever. Okay, how can you put the diagnosis that, sir, you are having rheumatic fever? How can you put that the diagnosis, the rheumatic fever? How can we keep the diagnosis? See, the diagnosis is done with the help of a criteria called as Jones criteria. Okay, so the criteria name is called as the Jones criteria, sir. So Jones here stands for J for, sir, if I am developing rheumatic fever, my joints will be affected, sir. Okay, antibodies will start to attack the joints, leading to arthritis. So joint involvement. O, write it like a heart symbol. Okay, like a heart symbol, sir. O for heart involvement. And N for nodules. Which nodules? Under the skin, you will start to see the subcutaneous nodules. I will show you. Okay, subcutaneous nodules. And E stands for erythema marginatum. On the skin, you are going to see the rash, which is called as the erythema marginatum. Erythema is going to be seen, especially in the margins. I will show you the image, which is called as the erythema marginatum. And S stands for Sydenham's chorea, nervous system involvement. Sydenham's chorea, sir. Okay, nervous system antibodies will start to go and attack the basal ganglia region, leading to the Sydenham's chorea. Okay, JONES. What I am trying to put into your mind is, sir, if I am the person who is having rheumatic fever, okay, rheumatic fever, what is the criteria used to put the diagnosis? Jones criteria. Okay, modified Jones criteria. Sir, according to the Jones criteria, what are included in rheumatic fever? JONES, joint involvement, heart involvement, nervous system involvement, erythema marginatum, okay, erythema marginatum, subcutaneous nodules, and Sydenham's chorea, sir. Okay, now we will come one by one, sir. One by one. The most important thing is heart involvement. Okay, the heart involvement. So, inflammation of the heart. The antibodies will start to attack the heart, leading to the inflammation, carditis. So, which carditis, sir? Endocarditis, myocarditis, or pericarditis? Which carditis is going to be seen? Now, look here. Let's begin with the pancreatitis. Okay, the entire heart will be affected, not just one layer. Entire heart will be affected, sir. So, there will be pancreatitis. In rheumatic fever, if the heart is involved, then it is called as rheumatic heart disease. Okay. Which part of the heart is affected? Endocardium, myocardium, or pericardium? Entire heart is affected. All three layers can be affected. Okay. So, pancreatitis. First, let's begin with the pericarditis. First, let's start with the pericarditis. I am starting with one, sir, pericarditis. See, if pericardium is involved, okay, which type of pericarditis it will cause? Later in tomorrow's class, we will discuss about different types of pericarditis also. There are serous pericarditis, hemorrhagic pericarditis, fibrinous pericarditis, different types of pericarditis is there. Now look here, this is the pericardium, sir. How it is looking like? Dekho. How it is looking like? It's looking like very cheesy butter kind of appearance, right? So this is called as bread and butter appearance of the pericardium, sir. Bread and butter pericarditis. Okay, fibrinous pericarditis or bread and butter pericarditis. Pericardium is affected. How the pericardium is looking like? It's looking like a bread and butter. So it is bread and butter pericarditis, a type of fibrinous pericarditis. Okay. So now imagine a child is coming to you. Imagine this is the child coming to you with a rheumatic heart disease. Now which part of the heart will be affected? Sir, all three layers can be affected. Endocardium, myocardium, pericardium can be affected. Okay. See, one more thing you should remember. Don't think every time there will be pancreatitis. See, any layer can be affected, sir. Any layer can be affected. Endocardium, myocardium, or pericardium can be affected. If there is pericardial involvement, now what you will hear, the patient is having inflammation in the heart, right? It's very pain will be there, and this boy is crying. When you try to auscultate, what you will hear is pericardial friction rub or auscultation. Okay, MCQ. On auscultation, there will be pericardial friction rub. And whenever the boy is continuously crying, and whenever you go for the ECG, okay, whenever you do the ECG, now there is ST segment elevation, okay, there is ST segment elevation, sir. Now You are just thinking, right? You might be a little confused, sir. Usually, first year students and second year students, they will know only till here. ST segment elevation is seen in myocardial infarction. See, not only in myocardial infarction, even ST segment elevation is seen in pericarditis. Pericarditis will show ST segment elevation, sir. Okay, so especially it is called as a concave. Okay, concave ST segment elevation. They will use the word concave. ST segment elevation. Okay, ST segment elevation. How it's going to be concave ST segment elevation. Okay. It's going to be seen something like this. There will be a concavity. Okay, there will be concavity, sir. So concave ST segment elevation is going to be seen. Okay. Apart from that, we have seen concave ST segment elevation as well as pericardial friction rub. And how we have to treat this condition? So pericarditis is treated by giving simply steroids. Steroids are enough. Steroids are enough. Going to treat the inflammation. Steroids are anti-inflammatory. Yes, they will decrease the pericarditis. Now, there can be myocarditis, myocardial involvement. Okay, the myocardium of the heart can be involved. If the myocardium is involved, then it is called as myocarditis. Okay, true. Now, that can lead to, if the myocardium is involved, so the muscle is getting involved. The muscle is going to become weakened. That will cause heart failure, sir. Congestive heart failure. The myocarditis can actually kill the patient, sir. Okay, so acute congestive heart failure, the heart is failing. If the heart is failing, if the heart is not pumping properly, what will happen? Now the blood will start to accumulate back. Now there is no forward blood flow. So the blood is starting to accumulate in the lungs, which will cause pulmonary edema. Okay, which will cause pulmonary edema. Okay, so this myocarditis, how we have to treat, sir. This boy is going to present to the clinic with the symptoms of acute pulmonary edema. Okay, you can hear the crackles, bilateral crackles are going to be seen. Okay, so how we have to treat this? We have to treat this by giving LMNOP. What is LMNOP? So you have to decrease this edema, pulmonary edema, by giving the drug called as Lasix. Okay, Lasix, sir. Okay, M for morphine. We have to decrease the pain. Lasix, morphine, nitrates. You have to give the nitrates, oxygen therapy, and even the positioning. Okay, P4 positioning. You will study this better in your internal medicine in your fourth year and fifth year. Whenever you are going to the internal medicine, then you will study better about them. LMNOP stands for Lasix. You have to give Lasix, morphine, nitrates. Okay, why nitrates? Nitrates are going to decrease the preload. Nitrates are the vasodilators. They will decrease the preload to the heart. Okay, and oxygen, you have to give the oxygen to the person, to this boy, and positioning. Okay, you have to not in the supine position. You have to make the position little upward. Okay, not in a supine position, sir, so that the venous return decreases, right? So what we are discussing about the carditis. There will be pancarditis. Pancarditis includes pericarditis. How to treat the pericarditis? Simply by giving the steroids. How we can know that the patient is having, how we can know that the boy is having pericarditis is by doing auscultation. There will be pericardial frictional rub. Okay, there will be frictional rubs, sir, because the pericardium is inflamed. And there will be ST segment elevation, concave ST segment elevation. Treatment is done by steroids. And myocarditis is treated by giving drugs, LMNOP. And endocarditis, from here important. For pathology, this is important, sir. Endocarditis. Sir, inside the heart, the endocardium, your heart valves, sir, the mitral valve, aortic valve. Okay, so the mitral valve, tricuspid valve, pulmonic valve, aortic valve, they're all made up of what? They're all made up of the endocardium. Endocardium, sir. Endocardium is forming these valves, heart valves. So in endocarditis, there will be valvulitis. Okay, valves are going to be affected. If the valves are affected, there will be stenosis or regurgitation. Mitral stenosis, mitral regurgitation can happen. Okay, we'll discuss one by one. Dekho, sir, endocarditis is there. I have explained you. What is the most common valve affected? Mitral valve is affected, sir. Okay, see why mitral valve is affected. There is a very big reason why mitral valve is affected. We no need to go in that much detail why mitral valve is affected. Why? Because mitral valve is present on the left side. On the left side, high pressures are going to be there. There is a big story, sir, for that. Now in pathology, what you should know is there will be pancarditis. Endocardial involvement will be there, leading to endocarditis. In endocarditis, valves will be affected. The heart valves will be affected. The most common valve that is affected is mitral valve, and the least common valve that is affected is the pulmonic valve. Okay, done. So least commonly affected valve is pulmonic valve, done. Now initially, dekho, from here the story is little important, sir, little interesting. Now imagine for the first time I'm having rheumatic heart disease. First time I'm getting the pharyngitis. Now in this pharyngitis, after the pharyngitis, I'm an unlucky fellow, the 3% of the population, I have developed the rheumatic fever. Now in this rheumatic fever, now my heart is also getting involved. Okay, not only joints, not only skin, not only central nervous system, my heart is also getting involved. So now I am having acute rheumatic heart disease, sir. Now first time if I am having rheumatic heart disease, first time there will be endocarditis, okay. So initially I will be having mitral regurgitation. Mitral valve is affected. What is the problem with the mitral valve? Mitral regurgitation. The mitral valves are not closing properly. They are not closing properly. So there will be mitral regurgitation. The blood from the left ventricle is going into left atria. Left ventricle say the blood is regurgitating back into the left atria, sir. So mitral regurgitation is seen in children, sir, initially. But second time, again I got the pharyngitis infection. Imagine I am living in a poor hygienic environment in slum kind of area. Again I will be getting pharyngitis. Whenever I get pharyngitis again antibody production, again heart is getting attacked. Third time, fourth time, with more number of infections, more number of heart involvements, more number of times the heart is getting affected, more number of times the endocarditis, more the number of times the mitral valve is getting affected. Initially there will be regurgitation. Regurgitation will heal, right? First the mitral valve is getting affected. It will heal. First time healing, second time healing, third time healing. So this healing at the end of the day with more number of attacks, there will be mitral stenosis. More the number of attacks, there will be mitral stenosis, sir. So that's why in adults, okay, whenever this boy, whenever he become the adult, because of the more number of attacks, he might develop mitral stenosis. Okay, so mitral regurgitation is seen initially, followed by mitral stenosis. What is the difference between them? More the number of attacks. Initially mitral regurgitation followed by mitral stenosis. Now देखो here, see this is the mitral valve. Okay, mitral valve. How it is looking like? Sir, this mitral valve, it is looking like a fish mouth. So there is fish mouth stenosis in rheumatic heart disease. What kind of mitral stenosis is seen? Sir, the mitral stenosis is going to look like a fish mouth. So it is called as a fish mouth stenosis. Simple. Fish mouth stenosis. Okay. Next, done. I have explained you. Sir, the patient, if initially what he is going to have? Sir, the mitral valves are involved. Okay, the mitral valves are involved. Mitral regurgitation is there. There is a jet of blood. Dekho. There is a jet of blood that is getting regurgitated into the left atria. A jet of blood is getting regurgitated into the left atria. Now, see, in this left atrial wall, because of this regurgitant jet of blood in the left atria, are you able to see this a white patch kind of appearance? So continuously with every heartbeat, from the left ventricle, the blood is getting ejected into the left atria, sir. Now this jet of blood is striking the left atria, left atrial posterior wall. So that is causing this patch kind of appearance or the plaque kind of appearance, which is called as a Meckelum's plaque. Okay, so what is this Meckelum's plaque? Where it is seen? Seen in left atrial posterior wall. Because of what? Because of mitral regurgitation. Because of the mitral regurgitation, the regurgitant jet of blood is striking the left atrial wall, causing this plaque, Meckelum's plaque, sir. Meckelum's plaque. Okay, so this is also completed. Fish mouth stenosis completed. Meckelum's plaque is also completed. The question that was asked in one of the FMG exams and NEET PG exams is Meckelum's plaque is seen in which chamber? It is seen in left atria. Seen as a complication of what? Seen as a complication of mitral regurgitation. Mitral regurgitation. Okay, in acute phase, in acute rheumatic heart disease, you will see mitral regurgitation. In chronic rheumatic heart disease, many number of times there will be mitral stenosis. How the stenosis is going to look like? Fish mouth stenosis. Done, sir. Next, what else you should know regarding the endocarditis? Dekho here. Sir, these are the heart valves. Okay, this is the mitral valve which is affected, sir. The mitral valve is affected. Valvulitis. Right? Valvulitis. Now my question to you is, see, the mitral valve is inflamed. Mitral valve is affected. Endocarditis, inflammation of the mitral valve. Now these mitral valves, they are beating, sir. They are closing, right? They are closing. Continuously they are beating and they are closing. So there will be damage to the mitral valve. Mitral valves are going to be damaged or not? Damaged, sir. Whenever there is a damage, their platelets will start to come and deposit in that area. Okay, platelets will come and start to deposit in that area, forming what? Forming thrombosis, or I should say small thrombus, which are nothing but called as the vegetations. So here, are you able to appreciate this small vegetations? So these are the vegetations, sir. Okay, now where you will see these vegetations? In the mitral valve. The vegetations are going to be seen along the line of closure. Okay, that's the exact place. For example, imagine, see, these are the two mitral valves, two mitral valve leaflets. Now wherever they will close, see, these areas are getting damaged because of the inflammation. Okay, now along the line of closure, you will see these vegetations, MCQ. Okay, the vegetations are seen along the line of closure. My question to you, sir, this rheumatic heart disease, the heart is getting affected. Is it because of the bacteria? No, the heart is not getting affected because of the bacteria. The heart is getting affected because of the antibodies. The antibodies are attacking the heart, not the bacteria, sir. So these vegetations are nothing but the platelet accumulations. Okay, so they are sterile in nature. There is no bacteria. The vegetations which are seen in rheumatic heart disease, they are going to be seen along the line of closure, and these vegetations are sterile in nature. Done. So one more important MCQ completed. Where the vegetations are seen along the line of closure. Again MCQ point. There is fish mouth stenosis of the mitral valve. Now next, what else? Now because the valves are getting affected, endocarditis, mitral regurgitation. Whenever there is mitral regurgitation, the blood is going from the left ventricle into the left atria. Will there be abnormal sound or not? Yes sir, there will be abnormal sound. Definitely there will be abnormal sound. So there is going to be mid diastolic murmur, sir. Just wait. Same. Let me put it this way. No, this is not, you should say auscultation when you do. Okay, when you do auscultation. So when the left ventricle is contracting, okay, when the left ventricle is contracting, the blood have to go into the aorta. The blood have to go into the aorta. But now when the left ventricle is contracting, means systole, during systole, when the left ventricle is contracting, because of the weak mitral valves, because of the inflamed mitral valves, there will be mitral regurgitation. So there will be systolic murmur. Okay, there will be systolic murmur. Mitral regurgitation is going to have, it is going to cause pan-systolic murmur. Okay, there will be pan-systolic murmur, sir. Okay, that's the one thing which I want you to know. Now next, other important point, one is pan-systolic murmur is heard. Okay, in mitral regurgitation, pan-systolic murmur is heard, sir. Okay, well and good. Now there is something called as flow murmur. In this rheumatic heart disease, even flow murmur is heard, sir. What exactly is this flow murmur? The flow murmur is also called as a Kerry-Coombs murmur. Okay, Kerry-Coombs murmur. What exactly is this is? Simple. Try to understand like this. Put it this way. Sir, when heart is contracting, now some blood have ejected into the left atria. Extra blood have gone into the left atria. Now this extra blood, whatever have gone into the left atria, now again this extra blood will come down, right? Okay, this extra blood, now it will flow down. Okay, it will flow down. During the diastole, whatever the extra blood goes up, now this extra blood, it is going to flow back again into the left ventricle. So this extra blood coming down into the left ventricle will also cause a little sound, sir. So that is called as a Kerry-Coombs murmur. So Kerry-Coombs murmur is a flow murmur because of the flow of that extra blood from the left atria into the left ventricle. Put it this way in a simple way, try to understand it like that. And it's seen during diastole. Okay, so it's a mid diastolic murmur. Okay, so there is pan-systolic murmur, true, because of the mitral regurgitation, and because of the backflow of blood, there is also Kerry-Coombs murmur, which is a mid-diastolic murmur. Mid-diastolic murmur, sir. In many of the exams, this question was asked. Kerry-Coombs murmur is seen in rheumatic heart disease. It's a systolic murmur or diastolic murmur? It's a diastolic murmur, sir. It's a mid-diastolic murmur. That's the best option. Okay, so what have we have seen? Heart involvement. Just as a recap. Okay, just as a recap, guys. Come on. Any doubt? Yeah, okay. Now let's put it this way. So heart involvement is going to be pancreatitis. So pericardial involvement will be there, bread and butter pericarditis, which is the example of fibrinous pericarditis. There will be pericardial friction rub going to be seen. Yes sir, excellent. Pericardial frictional rub, and there will be ST segment elevation, concave ST segment elevation treated with steroids. Done. And there will be myocarditis, which can actually kill the patient because of the congestive heart failure. And how can you treat this myocarditis? With the LMNOP. Okay, Lasix, morphine, oxygen, positioning, and nitrates. And very important, very important for the students is endocarditis. Endocardial involvement, the valvular involvement. Which valve is going to be most commonly infected? Sorry, not infected, inflamed. The mitral valve. Mitral valve. Initially there will be mitral regurgitation. With more number of attacks, there will be mitral stenosis. So acute phase, mitral regurgitation. In chronic phases, there will be mitral stenosis. What kind of stenosis? Fish mouth stenosis of the mitral valve. Because of the mitral regurgitation, what you will have? McClump's plaque. Okay, this McClump's plaque is seen in the McClump's plaque, sir. It is seen in the left atrial posterior wall, because of the mitral regurgitation. Okay, done. And what else, sir? So there will be damage to the mitral wall, leaflets. So at the line of closure, at the exact line of closure, you are going to see the vegetations. Sir, these vegetations are small. They are sterile vegetation. They are not septic vegetation. They are sterile vegetations which are seen along the line of closure. These vegetations are made up of what? Mainly they are made up of the platelets. The vegetations are mainly made up of the platelets, sir. Even other components are there. I will explain you. Vegetations are made up of what? Platelets, not the bacteria, Okay. Now, other MCQs which I want you to know is, sir, heart is getting involved. Okay. Myocardium is getting involved. Okay. Now, if you look, imagine the patient is dead, sir. Imagine, unfortunately, this boy, a 10-year-old boy, is dead. Now, when you do the biopsy, what you will see? Sir? So, in the heart, you can see something like this. Okay, dekho. So, this is the heart. In the myocardium especially, you can see here. So, there is a granuloma. Inflammation, sir. It's actually a granuloma, sir. What exactly you are looking here? See, there are lymphocytes, histiocytes. See, this granulomatous inflammation, the granuloma, which is seen in the myocardium, this granuloma is called as ash of body, MCQ. This is called as the ash of body, sir. The ash of body, what exactly is it? Sir, ash of bodies are nothing but the granulomas. These are the areas of fibrinoid necrosis. These are the areas of granulomas and fibrinoid necrosis with, let me put it this way. Okay, so you will be having ash of bodies. Okay, ash of bodies. It's a morphological examination. The patient is dead. So whenever you do autopsy and look here, so the ash of bodies are seen. These are the pathognomic MCQ. The pathognomic for the rheumatic heart disease is ash of bodies. So what exactly are these ash of bodies? The ash of bodies are nothing but a granulomas. It's a collection of what? It's a collection of lymphocytes, plasma cells, swollen collagen fibers, and histiocytes. Histiocytes are nothing but the macrophages, right? Histiocytes are nothing but the macrophages. Okay, so the area of the ash of body is nothing but a granuloma, sir. It's a granuloma. Okay, so they will ask you in your exam, sir, ash of bodies, in the area of ash of bodies, which type of necrosis is there? Fibrinoid necrosis. Again MCQ. Okay, this is a very important MCQ. Ash of bodies are pathognomic for rheumatic heart disease. Now, if you look here, sir, this macrophages, this histiocytes. Okay, I am showing you one histiocyte, sir, from this area. Okay, let's take one histiocyte. Dekho, here is one histiocyte. Okay, now this histiocytes, whenever you look how it is looking. The nucleus is looking like a ribbon. Okay, the nucleus is looking like a ribbon, sir. So these are ribbon-shaped macrophages. Okay, ribbon-shaped nucleus is present in these macrophages. Okay, so these cells are called as Anichkov cells. Okay, this they also say like they are looking like a caterpillar or ribbon shaped. Okay, there are multiple terminology that is used. So it's a caterpillar like nucleus. The caterpillar like nucleus. So these macrophages are called as Anichkov cells. So Anichkov cells are seen in rheumatic heart disease. Okay, they are seen in rheumatic heart disease, but even they are seen in normal myocardium also. But most of the time in your exam they will ask you Anichkov cells are seen in which disease? Which disease? Rheumatic heart disease. What are these Anichkov cells? They are ribbon shaped nucleus in the macrophages. Ribbon shaped macrophages are called as Ehrlichkopf cells. Ehrlichkopf cells are seen in ash of bodies. Okay, ash of bodies. Ash of bodies are example of ash of bodies. Okay, they are examples of fibrinoid necrosis. Fibrinoid necrosis. They are pathognomic of rheumatic heart disease. Rheumatic heart disease. Okay, so done. Cardiac involvement is completed. Okay, now I have said you what is the criteria? What is the criteria to establish that this baby is suffering with rheumatic heart disease? You know, the criteria is Jones, Jones. Out of Jones, what we have completed? O, heart involvement completed. This is the major thing, sir. 75% is the heart involvement only. Others are very simple. Now, देखो. So, diagnosis. Let's put it. Let's go in a like in a one by one order. So, diagnosis is made with Device Jones criteria. According to this Device Jones criteria, okay. Same. At least if you want to say, this fellow is having rheumatic fever. This fellow is having rheumatic fever. At least the patient should have first the history of group A heat streptococcal infection. Okay, the mother should say, yes sir, my child have suffered with group A beta hemolytic. She should say that he suffered with pharyngitis 3 weeks back or 4 weeks back or 1 month back. Okay, he suffered with pharyngitis 1 month back, sir. Okay, so there should be an evidence, there should be a history of group A beta hemolytic streptococcal infection. Along with this, the person should have 2 major criteria. Okay, along with this, along with the history of group A beta hemolytic streptococcal infection, the patient should have 2 major criteria. There are 5 major criteria. You know, JONES. There are 5 major criteria. Out of these 5, at least 2 major criteria should be present. Okay, 2 major criteria should be present. Or at least 1 major criteria should be there, along with 2 minor criteria. You don't know what are the minor criteria. Later I will explain you what are the minor criteria. Now, how to put the diagnosis that the patient is having rheumatic fever? Evidence of or history of group A beta hemolytic streptococcal pharyngitis, along with at least 2 major criteria or 1 major criteria with 2 minor criteria. You know the major criteria, JONES, out of which we have completed the heart involvement, carditis is completed. Now, let's see other major criteria. So, okay, now let's begin with the other major criteria, sir. So, first major criteria, the second major criteria that I am going to discuss is a migratory polyarthritis. Okay, migratory polyarthritis. What is this word, sir? Migratory. Say, the antibodies now will start to attack the joints also. First, my elbow joint will be affected. First, after 3-4 days, first my shoulder joint will be affected, followed by my elbow joint is affected, my wrist joint is affected, my hip joints, my ankle joint, my knee joints. So, there will be joint involvement. First, for example, my shoulder joint is affected. Now it is resolved, sir. Now, okay, the pain is reduced, the inflammation is reduced. After 3-4 days, my elbow joint is affected. After 3-4 days, it is reduced, everything is become normal. After that, my wrist joint is affected. So, there is a migration. So, migration of the inflammation from joint to joints. And that to which joints are getting affected? Large joints are not the small joints. Okay, this is not rheumatoid arthritis. Rheumatoid arthritis is different. This is rheumatic arthritis. Rheumatoid is different. Rheumatoid means the small. The proximal interphalangeal joints, distal interphalangeal joints are involved. Now I am talking about the large joint involvement. That too migratory. Okay, so first right, most commonly the large joints are going to be affected. Out of JONES, the earliest one to appear is this migratory polyarthritis. Okay, just within 2 weeks. Now I have developed the streptococcal pharyngitis. Within 2 weeks, I can develop this migratory polyarthritis. Okay, it's the earliest to appear, sir. I have told you that there won't be any problem. Yes, inflammation is there, it's going to be reduced. After that, one more joint involvement. So there is no deformity in the joint. There is no residual deformity. Okay, but in rheumatoid arthritis, that is different. That you will study in your rheumatology, sir. Okay, again that's also autoimmune disease, but there is deformity in the joint. Joints will become something like this. Deformity in the joint. But here there is no such thing. So no residual deformity. Okay. Let me put it this way. Guys, remember JONES. What are these? These are the major criteria. Joint involvement, heart involvement, JO, right? Heart involvement, subcutaneous nodules, erythema marginatum, synonym scoria. All these are the major criteria. Now, please listen with both your ears. Sir, joint involvement. What is a joint? Migratory polyarthritis, right? Migratory polyarthritis. See, in India, where the cases of rheumatic fever are more common, okay, more common, even monoarthritis, not migratory polyarthritis, not the migratory polyarthritis, sir. Just monoarthritis is enough. It can be taken as a major criteria. No need to wait till multiple joint involvement. Just even if one joint is involved, you can consider it as a major criteria. So in high endemic areas like India, monoarthritis is enough to consider it as a major criteria, sir. Okay, so again and again I'm telling you, this is not going to be a big problem. It will be resolved. Okay, it's a non-erosive arthritis. No deformities are going to be seen, non-erosive arthritis. But if the boy is having pain, if the boy or the girl, if they are suffering with the pain, if they are crying, you can give the non-steroidal anti-inflammatory drugs like aspirin or naproxen. Done. Simple aspirin, naproxen is enough, sir. Done. Okay. Next, what are the important points? Migratory polyarthritis, multiple joint involvement, large joints are involved, no residual deformity, non-erosive arthritis, no deformity. First symptom to appear is the migratory polyarthritis. In endemic regions, in high endemic regions like India, no need to wait till migratory polyarthritis, just monoarthritis can be taken as a major criteria. Done, sir. Treatment is done with aspirin. Next, synonym scoria. Okay, synonym scoria, sir. So J completed, O completed, joint involvement, pancarditis, cardiac involvement is also completed. Now let's talk about the synonym scoria. See, what is synonym scoria? Okay, it's a late manifestation, sir. Seen after 3 months, 3 to 6 months, sir. Some books even mention 6 months. So if today I get the streptococcal pharyngitis, to develop the synonym scoria, how much time I should wait? 3 months. So by this time the mother have actually forgotten that after 3 months who will remember that the child is whether having pharyngitis or not. Okay, it's a very late manifestation, so the late manifestation. So it's seen after 3 months. So what exactly is happening here? There will be involvement of the basal ganglia. The basal ganglia structures are going to be affected. So that there is involuntary, rapid purposeless fast movements. Okay, involuntary rapid purposeless fast movements. So the boy, he's sitting and he's doing all these abnormal movements. The mother or the others, like the school teachers might be thinking this boy is a naughty boy. He is doing all these unnecessary purposeless movements. Okay, but he is not doing it voluntarily. It is happening by automatic, involuntary. So because of this, he will be having poor handwriting. Okay, in the clinical question they can mention the boy is having poor handwriting. Because of this, he cannot have a proper grip. Okay, the basal ganglia structures, the motor structures are affected, sir. So he cannot write properly. There will be involuntary movements leading to bad school grades. Okay, bad school grades. Okay, he will be doing, like whenever you do examination, if you ask the boy to show his tongue, okay, he will be doing a snake-like movement, darting tongue, sir. Okay, the snake, how it will do, how it will take its tongue, okay, like that. I don't want to show. So it's a darting tongue. Okay, darting tongue will be seen. Okay, it's a like purposeless movement of the tongue, darting tongue. And if you ask this boy to have a grip, now give your finger to this boy and ask to have a grip. Now I can have a very tight grip, right? So this boy, because of the involvement of the motor structures, he cannot have a proper grip, very weak grip, so which is called as a milkmaid grip is going to be seen. MCQ, milkmaid grip, darting tongue, poor school grades with unnecessary purposeless movements in a child who had a recent history of pharyngitis. Think about rheumatic fever. Okay, so his reflexes are going to be decreased. Okay, and that too, let me tell you, sir, migratory polyarthritis, simple condition, not a big problem. In the same way, even the synonym scoria, it will also be self-resolving, sir, within 6 to 12 months, self-resolving. Okay, it will automatically resolve. No need to worry about this. Okay, but if the mother is worried because of this unnecessary purposeless movements, if the mother is worried, then you can give drugs like valproate. Okay, valproate, haloperidol, phenobarbital, the CNS depressants, they decreases the activity, sir. So valproate, haloperidol and phenobarbital can be used to treat the synonym scoria. But even after 6 months, the chorea is not coming down. Whatever the drugs you are giving, the chorea is not coming down, it's continuing. So medically refractory chorea, sir. Okay, if everything fails, it's a medically refractory chorea. Okay, so then what you have to do? Then the option is going to be IVIGs, intravenous immunoglobulins, MCQ. So for medically refractory chorea, you have to give intravenous immunoglobulins. But generally, for treating chorea, you can use valproate, phenobarbital, and haloperidol. So this is also completed, sir. Now, very important MCQ. First manifestation to occur is a migratory polyarthritis. Last manifestation to occur is Syndonam's chorea, sir. Last manifestation. So one is after 2 weeks, other is after 3 months. So do you think both these clinical features are going to be present at the same time? No. By the time Syndonam's chorea develops, this arthritis is already resolved, sir. Okay, so arthritis and chorea cannot coexist at a time. Why? Because arthritis is the earliest manifestation and chorea is the late manifestation. They are not going to be seen together. Okay, so JO and S are completed. Now what we are left with? Subcutaneous nodules, simple, sir, and erythema marginatum, one single slide. Same, you can have development of this subcutaneous nodules, nodular development, especially in the extensor region. Okay, especially in the extensor sites, it is going to be seen. Okay, so subcutaneous nodules seen in extensor surfaces, and erythema marginatum, you can have, say the boy is having a rash. Okay, and the rash also, say, look, the margins are having the erythema, so that's why erythema marginatum, sir. Okay, this is not a ringworm. Okay, so this is erythema marginatum, right? So usually the erythema marginatum is not going to be very well appreciated in the Indians because we are having a more darker skins. Okay, in the fair skin people it will be very much appreciated. Usually in the Indian population it's not well clearly seen. Okay, not clearly seen. So geographically red macular lesions. Okay, will be central white color with the margins which are erythematous. So done. So completed, sir. All JONES are completed. So J for migratory polyarthritis, O for pancreatitis, N for subcutaneous nodules on the extensor surfaces, E for erythema marginatum, the margins are going to be erythematous, and last S for Syndonam's chorea, sir. Okay, so all JONES are completed. Out of this major criteria, to put the diagnosis, to say that this boy is having, to say that this boy is having rheumatic fever, at least you need to have 2 major criteria. Okay, that's what I am telling you from the beginning. So you need to have a history of group A beta hemolytic streptococcal infection, at least with 2 major criteria out of this JONES, or 1 major with 2 minor criteria. Now you will get it out. Sir, we know the major criteria, 5 major criteria we know. Then what is the minor criteria, sir? What are the minor criteria? There are 5 minor criteria, sir. Okay, 5 minor criteria. What are they? Simple. Look here, diagnosis. We are discussing about the minor criteria now. What are the 5 minor criteria? Say, if this baby is having polyarthralgia, not arthritis, just not inflammation, just pain in the joints, arthralgia, polyarthralgia. Okay, and fever. Okay, if the boy is having polyarthralgia or fever or elevated erythrocyte sedimentation rate, okay, CRP levels, acute phase reactants, CRP levels are elevated, and prolonged PR interval in the ECG. Okay, prolonged PR interval in the ECG. Okay, in the ECG, you know, right? See, this is P wave, QRS, P wave. So this is the PR interval. Okay, this is the PR interval, sir. So this PR interval time, if it is prolonged more than 0.2 seconds, okay, it should be less than 0. Normally it is 0.1 seconds, sir. If it is more than 0.2 seconds, then it is called as a prolonged PR interval. Okay, in medicine you will study why there is prolongation of the PR interval, because of the ash of nodules. Okay, ash of nodules deposited in the conduction pathway. The ash of nodules will start to deposit in the conduction pathway. So PR interval is going to be prolonged, more time. Okay, but I don't want you to know all this minor details. Simple, sir. What are the minor criteria? There are 5 minor criteria. What are they? Polyarthralgias, fever, elevated erythrocyte sedimentation rate, elevated C-reactive protein levels, and prolongation of the PR interval. If you have any of them, you can consider it as a minor criteria. So, okay, what are the major criteria? JONES. Minor criteria: polyarthralgias, elevated erythrocyte sedimentation rate, CRP levels are elevated. Next, the prolongation of the PR interval and fever. So these are the 5 minor criteria. So done, sir. So major criteria is completed, minor criteria is completed. Okay. So now what are the most common cause of death? The most common cause of death in acute rheumatic heart disease is endocarditis. In chronic rheumatic heart disease is myocarditis. Sir. Overall, most common cause of death is myocarditis. Myocarditis, I have explained you. It will cause congestive heart failure and it can kill the patient. It can kill the patient, sir. Okay. So done. Now what we are more worried about? Just tell me what we are more worried about as a doctor. Say we are more worried about that first time a child came to you. Now he is fulfilling the Jones criteria. Jones criteria. Okay, modified, revised revised Jones criteria. He is fulfilling. He is having two major criteria. Two major criteria are there. That's it. A history of streptococcal pharyngitis and two major criteria are there. So done. Now you can say, okay, this boy is having rheumatic fever and rheumatic heart disease. If heart involvement is there, rheumatic heart disease. Done. Now what you are more worried about? Initially he will be having mitral regurgitation, sir. But in the future, if this boy who is living in a unhygienic area, in a slum area, in future if he again gets streptococcal pharyngitis, again he will develop the cross reactivity, molecular mimicry, again heart will be affected, again carditis. So more the number of attacks, he will develop the mitral stenosis that can actually kill the patient, more worse thing. So we are worried about the future infections. So how we have to prevent the future infections? Okay, see, now what we have to give to this patient is IV benzathine penicillin, sir. Okay, so we have to give IV benzathine penicillin intramuscularly for every 3 weeks. Means this fellow, for every 3 weeks he should come to the hospital. Lifelong he have to come, sir. Lifelong he have to come to the hospital for once every 3 weeks and he have to take IV benzathine penicillin. Why? Because this is unlucky fellow, 3% of the population. If in the future if he gets one more attack, he will develop mitral stenosis. So IV benzathine penicillin intramuscularly for 3 weeks. Why? This is a prophylaxis to prevent future sore throats. That is prophylaxis. For how much time you have to give? Lifelong treatment is ideal. Lifelong treatment is ideal. But practically this is not possible, right? Okay, 10-year-old. Okay, till he's, for example, if he's living for 90 years, for the next 80 years coming to the hospital and taking, it's not practical thing. Okay, so in the questions, see the patient is having heart involvement, rheumatic heart disease. Heart disease is there. Heart is affected, but also valves are affected. Mitral valve is also affected. Not just pericarditis or not just myocarditis. Endocarditis, valvular involvement is there. Okay, rheumatic heart disease with valvular lesion. So at least for 40 years you have to take the IV benzathine penicillin. Sorry, not IV, IM benzathine penicillin. Okay, for 40 years he have to take that. In a question if they are mentioning, sir, rheumatic heart disease there, heart involved, but not the valves, not the endocarditis, maybe myocarditis or pericarditis, that's it. So rheumatic heart disease without the valvular lesion. If there is no valvular involvement, you have to continue the prophylaxis for 21 years at least. Okay, 21 years is the best answer, sir. Okay, always lifelong treatment is best. If there is an option lifelong, go for the lifelong option. If you don't find that, if valvular involvement, if valvular lesion is there, 40 years. If there is no valvular lesion, at least for 21 years. Or if they mention simple rheumatic fever, they are not saying whether the heart involvement is there or not. Simple rheumatic fever, sir. How much time you have to take the prophylaxis? Okay, so 21 years, sir. If heart involvement is not there, then 21 years. If heart is not involved, 21 years. Heart is involved and the valves are involved, 40 years. Okay, heart and valves both are involved. Heart and valves in the sense if the valvular involvement is there, rheumatic heart disease with the valvular involvement, 40 years. Only heart involved, 21 years. Rheumatic fever, 21 years, that's it. Okay, so these are the important points which I want you to know. You know, already you have discussed, sir, arthritis, migratory polyarthritis. What we have given? Sir, migratory polyarthritis. Okay, aspirin, naproxen, non-steroidal anti-inflammatory drugs. Sir, pericarditis, we have given steroids. For chorea, we have given haloperidol, valproate, phenobarbital, we have discussed. For medically refractory chorea, what we have given? Intravenous immunoglobulins. Done, sir. For prophylaxis, what we have to give? IV, sir, not IV, IM benzathine penicillin for 3 weeks, lifelong. Okay. In one of the exams, this question was asked. Imagine I am the child, sir. Okay, I came to you. I am a 10 years old child. Imagine I am the 10 years old child who came to you. Now I am having rheumatic heart disease. Okay, rheumatic heart disease, sir. My heart is affected. Now what you have to give? You have to prevent the future attacks. You have to prevent the future attacks. So what you have to give? I am benzathine penicillin, lifelong you have to give me. Okay, or at least 41 years, sorry, at least 40 years you have to give me. Now, what if I am allergic to penicillin? And the boy who is allergic to the penicillin, sir. Okay, imagine I am the 10-year-old boy who is allergic to penicillin. So you are not supposed to give penicillin. If you give penicillin, that will cause anaphylaxis and that can actually kill me. So in this condition, what you have to give for prophylaxis? It's a macrolide, sir, azithromycin. Okay, in a patient who is having penicillin allergy, then the next alternative which you can use is the azithromycin. Okay, azithromycin. Okay, so with this, rheumatic fever and rheumatic heart disease, all important points are also completed. Okay, now this will be enough for today. In tomorrow's class, let's discuss about the infective endocarditis. Okay, infective endocarditis, and let's also discuss about the myocardial infarction and cardiomyopathies in tomorrow's class. Okay, hope the class is helpful.